Alright, so we think we'll start with endo. Anyway, endo is the easy part, so I'm sure by that time you'll be able to get the PDF ready. So we're looking at a condition where the antidiuretic hormone is defective. This is a posterior pituitary. So with the antidiuretic hormone, which is also known as vasopressin, okay, this is also known as vasopressin, or arginine vasopressin is the full name of this, okay, same as antidiuretic hormone. So two problems are there with this: either too much secretion is there, that is SIDH, or ADH, inadequate secretion is there. So inadequate secretion is diabetes insipidus, okay, or too much secretion is SIDH. So I can share the PDF after the class also, but I don't think there'll be any difference. It will be the same thing, I'm just underlining it, that's all. Okay, so if you look at the SIDH, ADH is increased. This is V2 receptors. It's going to act on the V2 receptors. You know that antidiuretic hormone acts on V1, V2 and V3. V1 is present in the blood vessels, V2 is present in the kidney. So by acting on the V2 receptors, it inserts aquaporin 2 channels. This aquaporin 2 channels causes the reabsorption of water, and as water reabsorbs, one of the consequences it will do is it will dilute the sodium. Okay, as the water gets reabsorbed, it will start diluting the serum sodium. So one of the main things that you see in this condition is hyponatremia. As the water reabsorbs, the plasma volume expansion results in release of natriuretic peptide. The natriuretic peptide cause natriuresis, and they cause the plasma volume to come back to normal. So this is one of the reasons why you will see this patient end up with euvolemia. Okay, so initial retention of water countered by NP release, natriuresis, and natriuresis doesn't come alone. With some sodium, water also goes out. Net effect, you end up with euvolemia. The main point that they ask in exam is, these patients have hyponatremia, they have euvolemia, they may have some amount of transient hypervolemia. Okay, some transient hypervolemia also possible. Okay, but mainly what you get is euvolemia over here. But of all the questions, the most repeated question that they've been asking in the last 10 years, if you see the questions, it is urine sodium. Now you should understand that you and me, any of us, we can dilute our urine sodium by drinking too much water. You drink too much water, extra water body will throw out on the urine, and when it throws it in the urine, you can dilute the urine sodium. But in this condition, what is happening is, the excess antidiuretic hormone will not allow the water to go. Antidiuretic hormone is reabsorbing the water back. Because the water doesn't go in the urine sodium continues to remain high. It will not get diluted. So as the water is getting reabsorbed back by ADH, the urine sodium cannot get diluted. So the most repeated point they ask in an exam is, patients with SIDH typically have a sodium upwards of 40. So 40 to 90 is typical sodium you get in SIDH. Less than 20 is unlikely. Okay, even if the fellow tries to drink water, normally when you drink water, you throw water out in the urine. This is not possible because ADH is inappropriate. It's not appropriate. It's inappropriate ADH. It will keep reabsorbing water and the urine remains concentrated. So this is a peculiar scenario, and this is the main question they keep asking in the exam. All are true about SIDH except urine sodium less than 20 is what you should look for. In this patient's urine is very concentrated, so it's going to be more osmotic than plasma. Plasma becomes dilute because the water retained is going to dilute the sodium, and this is why the osmotic force in the plasma comes down. As you all know, normal plasma osmolality is 280 to 290, but it starts coming down because the retention of water. One of the interesting things that happens in this patient is hypouricemia. Wherever antidiuretic hormone is high, you will see that the uric acid levels will come down. This is uric acid, be careful, not urea, creatinine. Uric acid levels come down. Okay, this is one of the features that you see wherever ADH is high. So two places ADH is high, SIDH and diabetes insipidus, nephrogenic diabetes insipidus. In both, you will find that the serum uric acid levels are very, very low. One of the dictums in endocrine is, we do the test, we try to suppress the hormone, and if we cannot suppress its pathology. So you give water loading test, and if you give 5% dextrose, let's say, normally ADH should get suppressed. If the antidiuretic hormone got suppressed by giving water, this is appropriate response. But inappropriate response indicates that ADH is continue to remain high despite giving water loading test. So this confirms the diagnosis. So what's the treatment in this patient? First is, if the sodium is slightly decreased, you know what the normal sodium is? 135 to 145. So if you find the sodium is 130 to 135, mild hyponatremia, just fluid restriction is enough. If the sodium is less than 130, you have to go for correction of sodium. You can also do V2 receptor blockers, that is Vaptans, Conivaptan, Tolvaptan, Lixivaptan. Okay, Lixivaptan. Then you have Satvaptan. So number of Vaptans now have come up. Okay, Lixivaptan. Okay, satriptan, conivaptan, tolvaptan, all these vaptans basically are V2 receptor blockers. So one aspect also is you can consider urea, but much before you use all these things, your ultimate goal should be to correct the underlying cause. Okay, you have to find what the cause for SIDH. The list is so big for SIDH, but broadly you should understand for SIDH you have the tumors of the lung and the brain, central nervous system, also the infections in this area, tumors, infections in this area. Okay, so tumors, infections of lung and brain, and then you have some drugs which are associated with SIDH. Now among these drugs, the anti-epileptic drugs, particularly carbamazepine, is important. Then in the chemo you should know about vincristine, vinblastine and cyclophosphamide. So these are the main conditions that are associated with SIDH. Okay, so tumors, infections of lung and brain, then carbamazepine, vincristine, vinblastine, cyclophosphamide. These are main things that are associated with causing of SIDH. You need to find that and you need to correct it. So if you look at the polyuria, so we saw a scenario of SIDH. Now looking at a patient with polyuria. Polyuria is somebody who's got more than 3 liters of output per day. Okay, this is a patient who's got more than 3 liters output. So, or if the patient is getting more than 40 ml per kg per day. Okay, more than 40 ml per kg per day. Okay, or more than 3 liters of output per day. So when you're seeing a patient coming with polyuria with more than his urine, this is per day. Okay, in a child this is how we calculate, in an adult is 3 liters per day. The two major conditions are either the fellow is drinking too much water or has got diabetes insipidus. So look at the basic concept here. If somebody is forcibly drinking too much water, this is called primary polydipsia. Okay, primary polydipsia. If somebody forcibly drink too much water, then naturally one of the important things that you will see is it will dilute the plasma and it will dilute the urine. So urine will get diluted, urine osmolality will be low, urine sodium will be low. So it will first dilute the plasma and then it will dilute the urine. If you see diluted urine and diluted plasma, so sodium low, and because of that plasma osmolality low. So plasma low osmotic, urine low osmotic, sodium low in the blood, urine sodium low, everything is low. This is forcibly drinking too much water. This is straightforward. But in comparison, if you're looking at a patient with diabetes insipidus, in diabetes insipidus is a scenario where patient is going on losing water. He may not be able to keep up drinking so much water proportionately. So the primary problem is loss of water. Diabetes insipidus, antidiuretic hormone either is not there or not working. In this regard, water is lost in the urine. If water went away, sodium is left behind and that will result in hypernatremia. This will cause the plasma to become hyperosmotic. Although the urine continues to remain dilute, urine will be given as around 100 milliosmoles in our exam, whether it is primary polydipsia or diabetes insipidus. Usually the number they give you is 100. So it is dilute, urine is dilute. But the plasma here is dilute in primary polydipsia. Here it will be high. This is because water went away, not salt. Salt is remaining, sodium is remaining. So that will cause hyperosmotic force in the plasma. And urine will be very dilute. This scenario, if you're getting, this is basically helping you differentiate whether this is diabetes insipidus or primary polydipsia. So in our exam, the anchor point is sodium. Now you know that the midpoint for sodium is 140. Okay, 135 to 145 you all know is the normal sodium. In general, one trick we use is if the sodium is going above 140, even if it is say 143, let's say, so still normal one, so 143 is normal sodium, but one thing we understand is it tending to go up because it must be losing more water. That's why sodium is going up. It's still normal, but 143 means it's more likely to be diabetes insipidus. In this condition, when the patient goes on drinking too much water, he'll dilute the plasma sodium. So sodium starts coming down closer to 130. So somewhere this side of 140. So somewhere in this range you will see 135 to 140 typically, or it may be below. It may be below 135 also, but definitely below 140 is more likely to be primary polydipsia. So in this regard, okay, so the PDF is basically OneNote actually. See if you can open it in OneNote and then take a printout. So, or you take part by part and then take a printout. If you try to do the whole thing, you will have problem. Okay, I just shared the OneNote, so that is converted into a PDF. So to summarize then, the anchor point in deciding whether it is primary polydipsia or diabetes insipidus is basically the serum sodium. Not that I'm not well, I'm doing continuous classes. Actually I had a class today also, and then they have kept one more session now. right? So you can see the sodium is low, and this here the sodium is high. So this is the main anchor point for us: sodium low, sodium high. That's a differentiator. Okay, and this, if you just look at this, I think you should be able to solve the problem in the MCQ to differentiate whether primary polypsia is the answer or diabetes insipidus is the answer. So if you do water deprivation test, it's the main test that we do. Now when you do water deprivation test, remember this is an inpatient test. You take away the water bottles from the patient, stop him from drinking water, the urine osmolarity should increase, and it should increase by 50% per hour. Okay, it should increase by 50% per hour. So if you find that the urine osmolarity is increasing by 50% per hour, it indicates that the ADH system is working beautifully. But if you do water deprivation test and urine continues to remain dilute, okay, it fails to increase. Sometimes the MCQ will tell you it will increase, but increase will be less than 50% per hour. So the trick over here is be careful. The increase in urine osmolarity is not much. So for example, if the urine osmolarity is 100, it will become 120. Now you might ask, sir, why is it increasing? This is a diabetes insipidus, ADH is not working. The idea here is once you cut the water intake, once he stops intake of water, some increase in urine osmolarity automatically will occur. This is not because of ADH however. If it were to be ADH action, it will increase by 50%. So you have to be cautious about this. Urine osmolarity here increases by 50%. It was 100 before the test. It became 300 after 1 hour. This is classical. But it is 100, it became 120, did not increase by 50%. This is suggestive of diabetes insipidus. So be careful. I've seen many students, they see it increase by 100 to 120, they say it's increased. No, this is not sufficient. It should increase by 50%. So once it's primary polydipsia, it's a psychiatric problem, refer to psychiatry. Here it is either central or nephrogenic. Give a desmopressin test and see if the patient responds to desmopressin is central, does not respond to desmopressin, it is nephrogenic. Treatment here is desmopressin and treatment here is thiazide. So this is the approach that you have for polyuria. Sometimes in our exam for polyuria, they'll tell you about something called osmolar excretion. Now what's the concept of this? See, when you have somebody coming with polyuria, earlier what we used to do is, we used to look at the urine osmolality. If the urine osmolality is dilute, if the urine osmolality is dilute or urine osmolality is concentrated, based on that we used to tell, if the patient is passing dilute urine, he's got free water clearance, lot of water, only water, not solutes. So only water, not solutes means we're talking about diabetes insipidus, which is central or nephrogenic, or this is a patient who has got primary polydipsia. Okay, primary polydipsia. These are all the conditions you are looking at. He's got more water loss, not solute. But if the patient has got solute loss, like glucose, and glucose can take water out in the urine, okay, or the patient is getting 3% saline infusion, let's say. If you give sodium will come out of the urine. So our idea, that means, is we just look at the urine. If the urine is dilute, a lot of water going out, it must be water loss. So diabetes insipidus, primary polydipsia. Patient has polyuria, but solute loss is there, glucose and saline, 3% saline. This is a very simple way. But now we understand that urine osmolality alone is not enough. You need to look at the volume of urine. So this urine osmolality into volume of urine together is called osmolar clearance. Osmolar clearance. In one of the exams, they, instead of giving urine osmolality, they mention osmolar clearance. This osmolar excretion rate or osmolar clearance, it is nothing but urine osmolality into urine output in liters. Urine output should be taken in liters. Okay, in 24-hour output to be taken in liters. If you're doing that, if the number crosses 1000, he's got osmotic, this patient has got osmotic diuresis. And this can be sodium chloride, glucose, urea, something is pulling water out and coming out. Okay, it may be glucose, maybe sodium. But if you're getting water diuresis, this is dilute water, then we're talking about the patient having either diabetes insipidus or primary polydipsia. And I already told you, if he drinks too much water, he'll dilute his sodium, this is primary polydipsia. If the water is going away, sodium concentrates. So this is the major differentiator for us. So be careful. Okay, be careful. The approach is urine osmolality, but sometimes you can look at the osmolar clearance. Okay, I'll reduce the volume and see if then the echo comes down. Okay, I'm reducing the volume here. Okay, see if this is better. Okay, I think this should be okay. Right, if you want me to reduce the volume a little bit more, let me know, because I can see still some amount of yeah, I think this is better. Right, okay. So this is the approach for a patient with polyuria. If you're looking at a anterior pituitary, then in the anterior pituitary, the most common functional adenoma is basically prolactinoma. So prolactin level normally should be less than 30 microgram per liter. If the prolactin is high, the most repeated question in our exam is they will tell you patient came with amenorrhea, patient has got some galactorrhea, what do you want to do? The most important point is rule out pregnancy. Now this, I don't know, for some reason this is the most repeated question in our exam. They'll tell you a female came with amenorrhea from past 4 months, she's got some galactorrhea, she's got some fatigue, what's the next test? Get a beta HCG done, urine beta HCG done, you want to rule out pregnancy. Next is hypothyroid. Hypothyroid, get a TSH done. Don't forget, all these things are very common. So pregnancy can come with amenorrhea and galactorrhea, just like prolactinoma. So unless you rule out these things, you cannot go ahead and look at prolactinoma. Okay, so metoclopramide, antipsychotic drugs, all these also cause the prolactin levels to increase because they block the dopamine action, and that's why the prolactin goes up. So investigation of hyperlactin always is in our exam, rule out pregnancy. The main consequences of prolactinoma are the triad of prolactinoma, we call it as amenorrhea, galactorrhea and infertility. Okay, amenorrhea, galactorrhea, infertility, that's the triad of prolactinoma. So what's the treatment you want to do in this patient is basically cabergoline. This is the drug of choice. But the problem is in young females, especially those who are coming with infertility as a complaint, they are going to be trying to conceive. So don't give cabergoline, it's teratogenic. So in pregnancy, you want to use bromocriptine. Now at this point, you should understand that even Harrison says keep most pregnancies, you don't have to use any drug. But if you are worried about possible pregnancy, then to prevent the teratogenicity, put the patient on bromocriptine. Also in pregnancy, in a microadenoma, we don't give drug. In a macroadenoma, we give bromocriptine in the treatment. Only one point you should know about pregnancy and prolactinoma. See, in pregnancy, normally prolactin goes up. So in a patient with pregnancy itself, prolactin goes up. With prolactinoma, it will go up more. The serum prolactin has no significance. How much ever high it might be, has no significance when it comes to pregnancy. It doesn't mean it's a small tumor or large tumor. Normally, prolactin and tumor size have a correlation. But in pregnancy, there's no correlation between the prolactinoma, the prolactin levels and the tumor size. So even a small tumor can produce high prolactin in pregnancy. So its size is nothing to do with the serum prolactin level. That's an important point to remember. So in pregnancy, most microadenoma has nothing to do. In a macroadenoma, you follow up with visual field charting you do. If there is visual field problem, then you start bromocriptine. If it worsens, then you consider surgery, otherwise nothing. Okay, so pregnancy prolactinoma, one question has been asked in the past some time back, but this is what you need to do. The only trick is, normally if a patient is non-pregnant, higher the prolactin level, the prolactin may correlate with the tumor size. It has no correlation because pregnancy per se prolactin goes up. So even small adenomas can produce large prolactin, so size does not have any correlation with the prolactin level. If you see a patient with macroadenoma, the patient has visual symptoms, what do you want to do? Okay, what visual symptoms you can get in these patients? You can get bitemporal hemianopia. Remember, the tumor enlarges from below, it will compress optic chiasma. So this is going to result in a patient developing bitemporal heteronymous hemianopia. In that case also, that means even in a macroadenoma, the treatment is cabergoline. If within 1 week, if the patient shows no improvement, then you should take the patient off for surgery, otherwise the visual symptoms will become permanent. And the surgery that we do is transsphenoidal resection. Okay, it is transsphenoidal resection. If you look at acromegaly, the word acro means ends will become large. Acral areas. What are the acral areas? The hands, the skull, the feet, they will become large. This is known as acromegaly. So in this condition, what you're saying, the hands are large, the feet is large, the skull is large. Okay, all this is known as acromegaly. So in the hands, basically what you will see is the patient have frequent ring size change, or the patient have carpal tunnel syndrome. When you shake hands with these patients, you get a peculiar thing, and this is known as moist, doughy handshake. Generally, they mention this in the exam. Okay, moist, doughy handshake. Now, why is it moist? This is because there is increased sweating. Dough is basically soft tissue increased, very large hands. So you get this moist, doughy handshake. In the feet, what we're looking at is frequent change of shoes may be given, but the important thing is heel pad thickness will be very increased, significantly increased. In the skull, in this patient, you're looking at squaring of mandible. So prognathism can occur, squaring of mandible can occur. These are changes that occur in the skull. These patients also have a thickened tongue, macroglossia, and that's why their pronunciation and the fluency of speech is affected. They also have laryngeal changes, so voice becomes deep. Hypertension is a known feature because growth hormone causes sodium retention, diabetes can occur, cardiomegaly, left ventricular hypertrophy, and all these put together is the reason why these patients develop ischemic heart disease and die. So many of these people in this wrestling and all that, when they have this disease, they look quite massive, but you may think that they look so healthy, they live for 100 years, but they die prematurely, 48-50 years. This is because of ischemic heart disease. Arthralgia can occur, arthritis can occur. Then you have polyps. This patient is high risk of colon cancer. Now this colon cancer in India, the risk is not much, kind of diet that we have, but it is one of the top killers in the US. Vertebral bodies also become large, so spinal stenosis can occur. Okay, and don't forget I told you moist doughy handshake. So all these are features that occur in patients with acromegaly. Now the main question in acromegaly they'll ask you is what you should not do. Don't check growth hormone level alone, it's useless. Okay, it's fluctuating growth hormone, so it doesn't have any significance. So in this, what do we start with IGF-1 level? Okay, start with IGF-1 level. If the IGF-1 level are normal, rule out the condition. If the IGF-1 levels are increased, then only go for confirmatory test. Okay, never do growth hormone, it will fluctuate like crazy, so it has no value at all. Remember that. Okay, start with IGF-1. IGF-1 normal, rule out. Okay, it's normal, then rule it out. IGF-1 increased, then go for confirmatory. Confirmatory test is oral glucose suppression test. Once you confirm the diagnosis, get an MRI done. If the tumor is small in the pituitary, resectable, go for transfemoral resection. If the tumor is not resectable, you can do some debulking. You can do radiotherapy or focal ablation techniques, but ultimately most of the patients end up on drugs. 2 drugs we can choose depending on how the MCQ is asking. If the concern is local level in the tumor, if the tumor is compressing surrounding structures, then you can shrink the tumor by octreotide lanreotide. But if your concern is the growth hormone per se, then to block the action of growth hormone, we can use a drug called pegvisomant. So last year NEET asked this question. Pegvisomant is what? It's a growth hormone receptor blocker. Okay, so this has been asked recently. This might get repeated, so you should know. Now one thing we also understand is blocking the estrogen receptor also has some partial growth hormone blocking activity. So even anti-estrogenic drugs are showing some benefit. In all pituitary tumors, you will come across one idea that you should give a trial of cabergoline. Sometimes it works. It may not be a prolactinoma, but still cabergoline works. If it's a Cushing syndrome, it's a pituitary adenoma, or a growth hormone tumor, Harrison says give a trial of cabergoline. In some patients it will work. So if it works, good. If it doesn't, then we just give it a try. So this is all the thing. Of all the questions in acromegaly, the most repeated question is, in the investigation what you should not do is don't check the growth hormone alone. Okay, checking the growth hormone alone is useless. So starting always is IGF-1. Then you can use growth hormone as a part of the oral glucose suppression test. Just growth hormone alone is useless. Then if you look at the Cushing syndrome major questions are on testing. The reason why testing is so important is many times in Cushing syndrome, when we confirm somebody has Cushing's, the recent guidelines are suggesting many of them actually turn out to be natural obesity or genetic cause. It's not Cushing's. So we are have a tendency to label somebody as Cushing's even though they may not be. So that's why testing is become more rigid now. So what are the main features in these patients? The most common problem is weight gain. Remember, weight gain can occur in Cushing, can occur in hypothyroid. Difference is hypothyroid is faster weight gain. This is very slow weight gain, especially in a pituitary adenoma. These patients have truncal obesity and thin extremities. Buffalo hump can occur. This is basically fat on the back, dorsal area. Supraclavicular, suprascapular fat can be there. Abdominal skin striae can occur. Now there are some defining features that will alert you this may be Cushing's. One is the truncal obesity with thin extremities. Okay, cortisol is basically a stress hormone. It will break the muscle, glycogen, everything, and that will be the reason why the limbs are becoming thin. The muscle is breaking down. That's why the limbs are thinning out. So these patients will come with abdominal skin striae. Even normal people can have purple skin striae on the abdomen. It should be wide, more than 1 centimeter. So this is a very important point. Hypertension, menstrual abnormalities. Remember, in hypothyroid you get menorrhagia. This comes with amenorrhea. And one very important point here you should understand is proximal myopathy. So I was telling you that cortisol breaks the muscle because it is a stress hormone. Its duty is to supply acute energy like glucose. So it is going to break the muscle. So that's why extremities are thin. Also you get proximal myopathy in this patient. This proximal myopathy in endocrine, one important idea is creatine kinase. They'll ask you, it will always be normal. If it's an endocrine cause for proximal myopathy, CK levels will not increase. Okay, like unlike a myositis, for example, where CK will increase. IQ abnormalities can occur in patients with Cushing's. Hirsutism can occur, easy bruisability because of a thin skin. This is another differentiator. Hypothyroid comes with thick skin, this is thin skin, and flushed appearance of the face. So what you see in this patient is, look at the abdominal striae, they'll be wide. This patient's limbs will become thinner because muscle is breaking down, proximal myopathy occurs. They have a thin skin, they have flushed appearance on the thing, they have the buffalo hum, so they have the pendulous abdomen. All these are features to tell you this is going towards Cushing syndrome. Now the main thing in Cushing's is the testing, and this is where the problems are occurring. Now whenever you want to do the initial testing in this patient, the first thing you want to do in a suspected Cushing's is confirm it. So in a suspected Cushing's, the first test you want to consider is doing an overnight dexamethasone suppression test. What is this overnight dexa suppression? Is basically you're giving 1 milligram of dexa at 11 p.m. in the night. Remember, dexa is a very potent glucocorticoid. It has got very good feedback to the pituitary, and the adrenal axis will get suppressed. By giving overnight dexa, you're just trying to rule out Cushing's in the first place. Next day morning, you ask the patient to come get the cortisol checked. If the cortisol got suppressed, you can rule out Cushing's. If the cortisol is not suppressed, then this still is not confirmed Cushing's. It may be Cushing's. Now the recent guidelines are telling that many people that we used to label as Cushing are not really Cushing. So first you do overnight dexa, 11 p.m. you give a tablet of dexa, next day morning 8 am cortisol. Remember one important idea, just cortisol without giving dexa in the night, any stress, sometimes even medicos for that matter, they stiffen up like anything when you show them the needle and syringe, even to draw a sample, and that is stressful enough for many to cause cortisol to shoot up. So just the mere sampling process can cause cortisol to go up. That's the idea. So don't just look at cortisol. It has to be done in the backdrop of DEXA. So DEXA you take, cortisol got suppressed, normal. Did not get suppressed, maybe Cushing. So the new thing now they are suggesting is you have to get multiple tests to be satisfied is Cushing. Number one, you should get a 24-hour urine cortisol. The problem with 24-hour urine cortisol, Harrison is saying, is see, doing 24-hour urine cortisol per se first is not justified on your part. Asking the patient to take a can, collect urine for 24 hours. First let the DEXA suppression test come positive. If it's negative, it's very easy, just rule out. This is very beautiful to rule out. But if it's positive, then you can tell the patient, okay, now you have to collect urine for 24 hours. And this is 3 times. Single time is not enough. Harrison is now telling 3 times 24-hour urine cortisol should be high. You can also do something called midnight or late night salivary cortisol. What is the logic over here is, when you're looking at salivary cortisol, first is you're not taking any sample for stress to cause the cortisol to increase. You know that normal cortisol levels are peak at 5 to 6 am in the morning, cortisol is going to be high. At 12 midnight, okay, 12 am to 1 am in the night, the cortisol is lowest. So lowest cortisol, highest cortisol, this is what is called diurnal variation. This diurnal variation is lost in patients with Cushing. So that's the reason why we are getting the midnight salivary cortisol, because in the morning sample, in the plasma cortisol is high. So in the saliva it will be positive. But in the midnight saliva cortisol will be negative, because in the plasma itself is very, very low. So we just want to see, is the diurnal variation maintained or lost? Earliest feature of Cushing's is loss of diurnal variation. So in the middle of the night, remember, you're not showing a syringe or something stressing the patient out. So you're not worried about stress induced thing. Cortisol in the plasma is low. In the saliva, it should be absent. So this is the idea behind using midnight salivary cortisol. Okay, it should be absent. Present is abnormal for us. So overall, nowadays, the problem is confirming Cushing's. Okay, this is the first step. The trick is never do MRI, never do ACTH initially. You are going to first confirm, and until you confirm, don't go for MRI and ACTH. So only when you confirm, then the role is coming. Once you confirm the Cushing's, then look at the ACTH. If the ACTH is low, it's a adrenal problem. If the ACTH is high, this is a pituitary or a ectopic problem. Okay, so I'll give it in a much more simplified way. Once you have confirmed the Cushing's, then only you are going to look at ACTH. ACTH is high or ACTH is low. If the ACTH levels are low, then you're dealing with adrenal pathology, because by feedback, adrenal tumor produces cortisol. By feedback, ACTH suppressed. If the ACTH levels is coming high, then you're dealing with either a pituitary adenoma or ectopic ACTH syndrome. And to differentiate between these two, you do high dose DEXA suppression. One of the platforms giving the answer is MRI. Remember, MRI again will take you in a false zone, because non-functional adenoma, you may pick that up and think wrongly that's a pituitary adenoma. So although Harrison algorithm mentions MRI in the algorithm, but in the theory they're explaining that imaging is last option. It should be high dose DEXA suppression to differentiate between pituitary and ectopic. So that is all the things about the diagnosis of Cushing's. The major MCQ zone for Cushing's is on diagnosis. They'll give you halfway and ask you what's the next step. So that algorithm is very, very important. When we look at thyroid disease, you should know about hypothyroid and thyrotoxicosis. So if you're looking at thyroiditis, which is important cause for hypothyroidism, Hashimoto's is the most common cause, and what you get here is anti-TPO antibodies. In general, any thyroiditis, iodine uptake will be low, with one exception, and that exception is Hashimoto. In Hashimoto, initially the attack is against the TPO enzyme, and the sodium potassium iodide pumps are working normally. Because the iodine pumps are working normally, iodine uptake initially is normal, later it will get affected. So be careful, iodine uptake in Hashimoto's is variable. Okay, radioactive iodine uptake is variable. It may be normal, it may be low, it is both. But all other thyroiditis, iodine uptake will be low. A damaged inflamed gland will not pump iodine. So subacute thyroiditis riddles, it will be low. Among these three, this condition looks like cancer. Because it's got fibrous tissue, it mimics like cancer. So sometimes they'll ask you an exam, and this is not riddle, this is riddles. So they'll ask you, how do you differentiate riddle thyroiditis from malignancy sometimes? Now both will be hard in consistency because this is fibrous tissue. Cancer also can be formed to hard in consistency. And the logic here is, riddles being a fibrotic condition, it is diffusely damaging the entire thyroid. So patients invariably will be hypothyroid. Whereas in a cancer, in a thyroid malignancy, one cell or few cells became malignant and they started growing. The normal tissue got pushed into the capsule. It got pushed in the capsule, but it's still functional. The tumor mass that is there is all malignant, correct? But there is a lot of normal tissue that is although displaced by the tumor, but it is still functional. So most cancers are euthyroid. Riddles is hypothyroid. So if you see a patient with hypothyroid, think about riddles. Otherwise malignancy, they are going to be euthyroid. So Hashimoto's is anti-TPO antibodies. It comes with other autoimmune diseases like Addison vitiligo, and the patho will show lymphocytic infiltrates. Okay, all these are features of Hashimoto. Subacute thyroiditis is a transient problem. It's a viral infection. Now what's interesting about subacute thyroiditis is the natural history of all thyroiditis is that initially they leak thyroxine and later they deplete the thyroxine. See, you get thyroid gland inflammation. Inflammation of the thyroid gland will cause whatever stored thyroxine is there inside the follicles, it will start leaking out. When it starts leaking out, the patient actually will be toxic. Problem is, most thyroiditis, by the time they come to us, they don't come in this phase. By the time they come, this thyroxine got depleted and the patient has gone into a state of hypothyroid. This is when you will see a patient with Hashimoto's, for example. But the reason why subacute we pick up early and they come with toxic symptoms is because this is going to come with severe pain. Their major complaint is pain in the neck, and they have tenderness in the thyroid. Invariably, these patients will be thyrotoxic. Whenever you see in an MCQ a patient coming with classical thyrotoxicosis description, your differentials are either it is Graves' disease or it is subacute thyroiditis. The answer comes in iodine uptake. Remember, in subacute thyroiditis, I told you the dictum, in all thyroiditis iodine uptake low except for Hashimoto's, right? So if you find that the radioactive iodine uptake is low, you're dealing with subacute. A Graves' disease come with homogeneous increased uptake. Okay, subacute thyroiditis, very low uptake, Graves' very high uptake. That's the difference. So this patient is thyrotoxic, but iodine uptake is low. Why is it low? Inflamed thyroid. So your uptake is not going to happen. It's a very transient condition. Within a few weeks, patient will normalize. Just need to give NSAIDs. Okay, just need to give NSAIDs in the patient. So all hypothyroid patients, the treatment is thyroxine. You give T4. In riddle thyroiditis is a fibrosing condition. There is exact reason why fibrosis is occurring. We don't know, but estrogen is playing a role in the fibrosis. That fibrosis causes compression findings like dysphagia, stridor can occur. And these patients will never be leaking thyroxine like other thyroiditis. It only has hypothyroid component. So from euthyroid, it goes directly into hypothyroid. So they'll ask you in the exam, which thyroiditis is never toxic? This is never toxic. In addition, these patients can have fibrosis of the palms, fibrosis in the retroperitoneum, Dupuytren's contracture, Ormond's disease, Peyronie's disease. These are also fibrosing problems, and the treatment is thyroxine plus anti-estrogenic drugs. Okay, this is supposed to slow the fibrosis, tamoxifen. If you look at myxedema coma, this is an extreme form of hypothyroid. In this patient, they are generally elderly females in the question, or they can be elderly people generally. They may have cold exposure and they may have a stressor in the background. The major dominating picture is altered sensorium. They come with delirium. So they may have altered sensorium, coma, psychosis. One clue will be the body temperature will be very, very low. Okay, body temperature is low. And they are going to have heart rate low, bradycardia will be there. Thick coarse skin. Okay, thick coarse skin they'll mention usually in the exam. Either a patient is a diagnosed case of hypothyroid who stopped treatment, or this is a patient who first time diagnosed with severe case of hypothyroid. So they'll have bradycardia, they'll have hypotension, they might have hypoxia, hypercapnia, because the respiratory centers are also getting suppressed. But the main clue comes in the form of TSH. Okay, TSH levels are grossly increased over here. In this regard, what you want to do in the treatment is give steroids and thyroxine. This is the first time you will give a combination of T3 and T4. We give T3 also, we give T4 also. Both have to be given in this patient. So, whenever we give IV, whatever oral dose you give, remember you give 75% of that when you're giving IV. So, everything else in myxedema coma basically is supportive care. When you look at a patient with thyrotoxicosis, look at Graves' disease, look at toxic adenoma, and don't forget the third one, subacute thyroiditis, which generally comes with very low iodine uptake. Both these conditions come with high iodine uptake. This is diffuse intake. So this is a TSH receptor antibody that is behaving like TSH. It will cause goiter and it will increase the iodide pump. It basically is activating the switch of the factory, that is the receptor, and the pump will increase and it makes new thyroxine. So excess thyroxine will cause biofeedback suppress TSH. So radioactive iodine uptake will be increased, and this homogeneous uptake. Normally in any patient when you do iodine uptake, the uptake should be 33%. This patient will be almost double, around 50-60% uptake will be there. In this condition, you get a hot nodule. You may get a solitary nodule, you may get a multinodular goiter. But the difference between the two, so iodine uptake is high in both the conditions. Difference is one is homogeneous uptake, one is nodular uptake. But the anchor point for us in our exam actually is this. Among the three conditions I am telling you that come with thyrotoxicosis, what is that? Graves, toxic adenoma, and subacute thyroiditis. Remember, the glycosaminoglycan is an anchor point. It is only seen in Graves. So the moment you see proptosis in the question, see this lid-lag sign, other eye signs, they can happen simply because of thyrotoxicosis, sympathetic activity. But deposition of glycosaminoglycan causing proptosis is unique for Graves' disease. So this proptosis, if they say opiotibial myxedema, clubbing is deposition of glycosaminoglycan in the fingers. All these are classical for Graves. Now they are known to occur glycosaminoglycan deposition only in autoimmune thyroid disease. So this autoimmune thyroid disease, one is Graves, which you know, the other is Hashimoto's. So even Hashimoto's can have some amount of proptosis, but it's very, very rare. Harrison says 5% of them. But as you know, glycosaminoglycan deposition is very high percentage wise in Graves' disease. Okay, in Hashimoto only 5% can have. So to differentiate between a toxic adenoma and a Grave, I would say look for proptosis in the question. Be careful, lid lag, staring sign, Stelvag sign, they are not going to help. Proptosis should be there. If it's there, it is glycosaminoglycan deposition. If you're looking at the calcium phosphate parathermal alkaline phosphatase, you must know the normal levels. It is 8.5 to 10.5, although most of them will be the 9s. The normal phosphate is 2.5 to 4.5. Parathermone level you don't need to remember. Alkaline phosphatase normal level is 130. Okay, less than 130 units. Now in a patient with parathyroid adenoma, hyperparathyroid parathyroid adenoma, calcium phosphate always go in the opposite direction. The rule is whenever you see calcium phosphate going in opposite direction, it's a parathermone problem. So calcium high, phosphate low, hyperparathyroid. Calcium low, phosphate high is hypoparathyroid. If you find that the calcium and phosphate are moving in the same direction, it's a vitamin D problem. If both are decreasing or both are increasing, it's a vitamin D problem. Now vitamin D deficiency is rickets and osteomalacia. But if you see a patient with vitamin D toxicity, where will you get it? In granulomatous condition, granuloma in sarcoid contains 1-alpha hydroxylase activity. By using this activity, sarcoid can convert inactive vitamin D to active vitamin D. That's known as vitamin D toxicity. Okay, that will result in vitamin D toxicity. So if you get vitamin D toxicity, calcium high, phosphate high. If you get vitamin D deficiency, calcium low, phosphate low. So in your exam, remember the rules. If calcium phosphate opposite direction, parathormone is a culprit. They move in the same direction, it's a vitamin D problem. If you look at malignancy, however, it does look like calcium phosphate moving in opposite direction. But interestingly, the parathormone levels are suppressed. So who's doing the job? What parathormone is supposed to do, somebody else is doing. And that is called PTHRP. This is known as parathormone related peptide. Okay, this is called parathormone related peptide. This parathormone related peptide is behaving like a parathormone. It's increasing calcium, decreasing phosphate, but the parathormone is low. This is very suggestive. This is nothing but what you see in malignancy. Okay, which cancer? Lung, breast, renal. The trick here in the MCQ, they'll ask you which lung cancer. Now many students have this idea, paraneoplastic is small cell. Be careful, parathormone related peptide is produced by squamous cell, not small cell. Be careful of that. So remember parathyroid, say for example Cushing syndrome is small cell. Or if you look at SIADH, it's small cell cancer of the lung, but not hypercalcemia. Hypercalcemia is squamous cell of the lung. So be careful of that. It's not small cell. Remember when you say osteopenia is decreased bone, osteoporosis is severely decreased bone. So many patients you will see in your OPD who have osteoporosis based on the DEXA report. Remember such patients, most of them will have a normal lab report. So in this condition, the problem is not in mineralization. It's simply the bone is not there. For the bone, unless it's there, calcium can't be deposited inside it. So be careful of this. Osteoporosis and Paget's disease, two conditions they'll tell you calcium will be normal. So here the patient is going to have normal calcium, normal phosphate. In a patient with multiple myeloma, this myeloma patient has the predilection of producing the plasma cell, which is malignant here, produces osteoclast activating factors. Mainly there is something called rank ligands. These rank ligands directly stimulate the osteoclast. Okay, the rank ligands. Remember the pattern of lung cancer causing is parathormone related peptide. In multiple myeloma, it's not parathormone related peptide. There is something called rank ligands that are produced. These rank ligands, okay, they are the problem. They will break the bone, they activate the osteoclast. So as the bone is broken, calcium phosphate will spill out. Initially they will spill over and go in the urine, but eventually they'll start increasing in the blood. That's why in multiple myeloma you get something called Crab symptoms, hypercalcemia, renal failure, anemia, right? So calcium is high, phosphate is high, by feedback parathormone is suppressed. But the interesting aspect is, because alkaline phosphatase is a blastic marker and blasts are not involved in multiple myeloma, the alkaline phosphatase levels are normal. Okay, this is an important question they ask in exam. Remember, alkaline phosphatase myeloma is normal. Then you should know about something called hypocalciuric hypercalcemia. Okay, so make the correction over here. This is hypercalcemia. Hypocalciuric hypercalcemia. In this condition, actually there's a defect in the calcium sensors. This calcium sensing receptor is defective. So if the parathyroid gland that should produce parathormone, it's supposed to maintain the calcium. The feedback is via this receptor, and this receptor is defective. This scenario is called familial hypocalciuric hypercalcemia. Without the feedback, the parathyroid does not have adenoma here, but because it doesn't get the feedback, it produces more parathormone, and that will look like as if the patient has a hyperparathyroid picture. Because by feedback, without feedback rather, more parathormone will come out. That will increase calcium, decrease phosphate. When you look at the initial report, it looks like hyperparathyroid, it looks like a parathyroid adenoma, but the clue in the MCQ will be that remember that in the blood vessels, in the nephron, in the kidney, okay, this is the kidney. Instead of showing the nephron, I'm just showing the kidney. Inside the blood vessels in the kidney, the calcium sensing receptor senses calcium in the blood. This calcium sensing receptor is defective. Normally what it should do, when it senses the calcium, it does not allow reabsorption of calcium. Whatever calcium is there should go in the urine. Okay, urine calcium should increase. So whenever it's high in the blood, it should go in the urine. But calcium sensing receptor is defective. Even though calcium is high, it's not sensing it. In fact, it's sensing it as low calcium. It is sensing as low calcium. It will reabsorb the calcium back and it will not allow the calcium to go in the urine. So what you end up in this patient is seeing a low urine calcium. This is contrary to what would happen in a hyperpara. In a hyperpara, calcium will spill over in the urine thanks to calcium sensing receptor. This is the reason why patients with hyperpara come with renal stones. These patients will not come with renal stone, and that's why it's called as hypocalciuric Okay, this is hypocalciuric hypercalcemia. So hope you understand hypocalciuric, low urine calcium, high calcium in the blood. So the defining feature for us, FHH, number one is typically this will present below 30 years, whereas primary hyperpara will be above 30 years. Second is the mention of low urine calcium or a low urine to creat ratio. That point will highlight to you that this is a patient who's got FHH. There are no renal stones, there is family histories, parent, brother, sister, somebody will have it, and the presentation is below 30 years. So last time the question came, they said 22-year-old boy came with high calcium, low phosphate, high parathermone, and the urine calcium was low. Somewhere in one corner they mentioned urine calcium low. The answer is FHH. The age is the clue. The urine calcium being low is a clue. Look at those points. When look at the adrenal problems, look at Addison's and secondary adrenal insufficiency. Addison's is basically an attack against the adrenal layers. So you have the zona glomerulosa, fasciculata, reticularis, all are attacked. So all are affected. Obviously medulla will not be affected, medulla is normal, but all are affected. This is the reason why you will find even melanocorticoids are low, glucocorticoids are low, both are low. In a patient with secondary adrenal insufficiency, the RAS pathway is normal. Aldosterone normal, androgens normal, only the cortisol is low. Because the ACTH is only controlling cortisol, RAS feedback controls aldosterone, that is not affected. So between the two, you don't see so much of hypotension or hyperkalemia in secondary adrenal insufficiency. You will see it in Addison's. So Addison's in our exam, typically they'll describe a patient who is coming with syncopal attack. This is because of a volume contraction in the plasma. So main clue in Addison will be a patient with syncope and abdominal pain. Apart from that, you can see this patient coming with pigmentation because of the high ACTH. So when you see these pictures, then your main concern here is how do you work up this patient. So in the workup, start with 8 m cortisol. Remember, we never do cortisol alone in a Cushing's patient because any stress, cortisol can be high. Here we don't care, even if it is due to stress. You are showing a big needle and syringe to draw the sample. That's enough stress. Still cortisol is low and the cortisol is less than 3. We don't need anything else. It is Addison. Look at the ACTH. If it's high, so what do you start with first? Look at the cortisol. Less than 3 microgram per deciliter plus high ACTH. That is enough for us to tell this patient has got Addison's disease. You don't need anything more. But if you find that the cortisol is more than 18 microgram per deciliter, then you can rule out Addison's. Even if it is stress induced, doesn't matter for us. Adrenal is responding now. It's not Addison. If it is between 3 to 18, okay, this is given 3 to 15, but actually in the standard books is 3 to 18. So if it is between 3 to 18, then we have to go for the short synactin test. Okay, this short synactin test is also called as the cosintropin stimulation test. Both are the same thing. What you're doing here is you're giving an injection of ACTH, which is, we have a kind of synthetic ACTH, which is a shorter form of the actual ACTH in the body. We give 250 micrograms ACTH injection, and 1 hour later, 2 hours later, we check the cortisol response. If the body responds to the ACTH, that's normal. If the cortisol does not respond to the ACTH, it confirms the patient has Addison's. So this is how the workup is done. So remember, in a Cushing, you never start with cortisol. Here you can start with cortisol. Cortisol is directly low, ACTH high, Addison in. More than 18 rule out. 3 to 18, do the stimulation test. Give ACTH injection and see. Cortisol responds, it is normal. Cortisol does not respond, it is Addison's. Once you have diagnosed, then remember you have to work up for TB and you have to look for 21 alpha hydroxylase antibody, because the top 2 conditions for Addison's are autoimmune and tuberculosis. You have to rule out those. You have to work up for those. The treatment in patients is basically oral hydrocortisone, and hydrocortisone is given 15 to 30 milligram per day in divided doses. That's the treatment for patients with Addison. Okay, generally what we do is start 10 milligram in the morning, 5 milligram and 5 milligram. So 10 milligram early morning 6 am, then around 10-11 we give 5 milligram, around 4 o'clock we give 5 milligram. That's it. That's a day's treatment. So we start with that generally. That's a treatment for Addison's. If you look at the pheochromocytoma, the tumor, and don't forget, everybody with Addison should have a bracelet in their hand saying they have Addison, because if they meet with a road traffic accident, or they develop an MI, or they have a stroke, or they develop any infection, in the hospital, under stress, the body needs high amount of steroids. what he is taking orally may not be sufficient. So they need to give a lot of steroids in such a patient. If you're looking at a patient with pheochromocytoma, the typical question will tell you either the patient has got a medullary thyroid carcinoma, what investigation you want to do next. Any thyroid tumor, don't take the patient for surgery, especially medullary thyroid carcinoma, unless you rule out pheo. Because if you have a medullary thyroid cancer and you take the patient to the OT, on table if catecholamines come out, the patient will die on the table. So the patient is collapsed under the hypertensive spike. The bleeding will not be under control. So this is one way how they'll ask. The patient has got medullary thyroid cancer, is going for surgery. What do you want to work out? You want to work up for pheochromocytoma. Remember, most pheos produce norepinephrine. The classical triad in our exams is headache, palpitation, sweating. Okay, these three things you're seeing: headache, palpitation, sweating. Classical triad of pheo. Most common extraadrenal location, most of them are located in the adrenal. The most common location outside the adrenal is organ of Zucker-Kendall. This is an area from superior mesenteric artery till bifurcation point of the aorta. And most of them actually will be at the level of the inferior mesenteric artery. Around the inferior mesenteric artery you will find them. This entire zone from SMA to bifurcation point is known as organ of Zucker-Kendall. Okay, this is the periaortic ganglia that are converting into pheo. In the investigation, do not answer VMA. VMA is gone. Vanillyl mandelic acid is gone. Get the metanephrine assay and catecholamine. Although we use the term metanephrine, remember we check metanephrine and normetanephrine. Okay, when you send for testing. You can also do in the plasma. Plasma also you can do metanephrine. The advantage of plasma is urine has to be 24-hour urine. Plasma is going to be less stressful. You can just do free metanephrine and catecholamine assay in the plasma. So plasma is much more easier to do, but more expensive plasma. Urine is more reliable actually because it's collecting 24-hour. When you take a sample at that point, what is happening, it will show you. Urine in that sense is much more accurate. So as you know, the word accuracy means it's an average of sensitivity and specificity. Okay, so both tend to be high in the urine. Plasma is also equally good. It's less cumbersome on the patient. Once you have diagnosed, and this is enough to diagnose, don't have to do VMA anymore. Once you have diagnosed, your job is to locate. For localizing the tumor, MRI is superior to CT. If the tumor is located in the adrenal, still MIBG is needed to see for metastasis. If the tumor is not there in the abdomen, because what you do is abdominal MRI. It's not there in the abdomen, still MIBG, because it might be outside the abdomen in the thorax or the head and neck ganglia may be there. If they ask you which is the best, however, or the most accurate, the answer is the Dotter-Tate. This Dotter-Tate PET scan is now considered to be the best. Dotter-Tate PET scan. Even though it's the best, it's not investigation of choice for locating the tumor because it is done with CT and so much radiation exposure not needed. MRI is enough for most patients. MRI MIBG protocol we are following is good enough. That's the investigation of localization. But if they ask you which is the best, then you can go for the Dotter-Tate PET scan, and that is considered to be the best overall now. The important trick in the MCQ is in pheo, never give beta blocker alone. As you all know, anything that you do that can kill the patient is guaranteed MCQ in our exam. In a condition of pheochromocytoma, the vessels that are there, they are significantly constricted. So if these branches are there, the organs, these vessels are severely constricted. This is because catecholamine, remember that is raising here is norepinephrine, not epinephrine. Norepinephrine has got very good alpha-1 action and very good beta-1 action. By its beta-1 action, inotropy will occur, so heart is pumping the blood out nicely, but it's also constricted the vessel thanks to the alpha-1 action. The correct method of treatment is first you relax the vessel, then you relax the heart. But if you give a beta blocker first and you take away the effort of the heart, then through the constricted vessel, the organ perfusion will collapse. If that happens, the patient will actually worsen. So what you are not allowed to do in a pheo is give beta blocker alone. What you can start with is an alpha blocker. So we give phenoxybenzamine. Once alpha blocker is successful, then only give a beta blocker. And then go for surgery. Now in this regard, you should be careful that if they give you which drug you should not use, bisoprolol or labetalol, between the two, then ideally speaking, we would blocker. Labetalol is alpha and beta blocker, correct, but it is 1:7. Alpha is to beta blocking. It blocks more beta than alpha. We more happier if you have more alpha blockade than beta. Bisoprolol is pure beta blocker, so it is strictly contraindicated. In one exam they asked which drug you should not use. Labetalol is there, bisoprolol is there. Definitely bisoprolol is more worse because pure beta blocker. At least this has got some alpha action. So we can consider labetalol, but still when you use labetalol, better to add a alpha blocker. Now at this point, remember all this management in stable patient. The patient has a hypertensive emergency and he has got a pheochromocytoma and is coming with chest pain. This is ischemic heart disease now, secondary to high blood pressure. In such a patient, you are supposed to use alpha and beta blockers simultaneously. Normally in stable patients, alpha plus beta, but in a hypertensive emergency, you can use alpha beta blocker together because any rapid drop in blood pressure, reflex tachycardia will occur. So reflex tachy we are blocking by giving a beta blocker at the same time. So alpha beta together, you can use labetalol plus phentolamine, or you can use, so basically make sure that heart is protected in an acute patient whenever you go a rapid drop in blood pressure. In a stable patient, phenoxybenzimane decreases BP over 2 weeks. You don't have to give beta blocker initially. Once alpha block is successful, then add a beta. But in this is rapid treatment. Phentolamine, if you're using, let's say, it will drop the pressure rapidly, reflex tachy will occur, tachycardia can precipitate more cardiac damage. So you have to protect the heart also. So you give alpha and beta generally in hypertensive emergency. Main thing is don't use beta blocker alone. In a pheo, don't use beta blocker alone. If you're looking at a MEN syndrome, MEN1 is 3 P's. Okay, you must have all known the mnemonic warm her please. Okay, so the 3 P's are parathyroid, pancreatic, pituitary. But this is a trick here. Not really pancreatic, it is actually enteropancreatic, because you know that gastrinomas don't occur in pancreas. They mainly occur in the duodenum. Okay, that's why the correct term is enteropancreatic. So what you see in this, basically, because of the parathyroid, calcium is high. Because of this, mainly gastrin levels are high. Okay, and gastrinomas are more common than insulinomas actually. And then pituitary, mainly it is prolactin, so prolactin will be increased. So the typical question they'll ask you is, let's say patient has got high calcium, high prolactin, what else you can expect in this patient? So what you expect generally is a patient having peptic ulcer disease. Look at the high gastrin level. Fasting serum gastrin level is what you want to check in this patient. So this is how the workup is. They'll give you 2 things and ask you what is the third thing. So that's one way. If you look at MEN2 and MEN2B, both have medullary thyroid carcinoma. Both have pheochromocytoma. That's why whenever you have medullary thyroid carcinoma, you cannot take the patient for surgery unless pheo workup has been done. Sometimes it's like a hidden volcano that will suddenly erupt and release catecholamine, and that can be disastrous if it's done under stress on table in the OT. That can be harmful. So any medullary thyroid carcinoma, remember that never take the patient for surgery unless pheo is ruled out. One difference, and this is asked in the NEET exam recently, what is the difference between MEN2A and 2B? And MEN2A and 2B, the difference is parathyroid. So this always written parathyroid hyperplasia. Now we understand it's actually parathyroid adenoma. So parathyroid adenoma occurs in MEN2 but does not occur in MEN2B. So be careful. Adenoma is the difference. No parathyroid in MEN2B. Remember, it used to be called as MEN3 earlier. Okay, MEN3. But in MEN3 or MEN2B, whatever you want to call it, no parathyroid. Now you can get mucosal neuromas. You can see the patient having meridilated nerves in the cornea, megacolon. These things can happen both 2A and 2B, more in 2B than 2A. But main question is the parathyroid. They keep asking what's the difference between MEN2A and 2B. No parathyroid in MEN2B. Remember that. Now MEN4, when you see parathyroid in pituitary, your initial assumption is this is MEN1, because this is how MEN1 will come, parathyroid and pituitary. But it stops here because you don't see enteropancreatic. What you see is the patient has lower tract tumors. Lower tract tumors means what? Adrenal tumor can occur, renal tumor can occur, genital tumors can occur, testicular cancer, cervical cancer. So lower tract cancers plus parathyroid pituitary is MEN4. Okay, MEN4. When you look at diabetes, the fasting glucose more than 126, postprandial more than 200. The patient has symptoms: polyuria, polydipsia, polyphagia, paresthesia, and many times these patients actually come with some acute weight loss. Okay, so be careful. They are actually obese people, but recently weight loss occur in an obese person. Some weight loss occurring recently actually indicates that they may be having diabetes being diagnosed. This is now very severe. Cells are starving, so some weight loss can happen. So in this patient, the HbA1c obviously is another thing. Look at 6.5, and remember, you are going to do generally 2 things. You do the fasting and the HbA1c in most patients, because postprandial needs the patient to take 75 gram glucose, wait for 2 hours. It's cumbersome. So typically the 2 things we end up doing in most patients is the first one and this one. Now in this regard, if both are abnormal, it's enough to diagnose diabetes. If one of them is abnormal, then whichever is the abnormal one, you need to repeat that on a separate day. Okay, that's how we make the diagnosis of diabetes. Remember, common problem in India is that HbA1c can be falsely high in patients with iron deficiency anemia. Okay, even a simple iron deficiency anemia can cause the HbA1c to be falsely high. It's not just hemoglobinopathies. In hemoglobinopathies, we cannot look at HbA1c, but even iron deficiency anemia, you have to be cautious about interpreting the HbA1c. Now they are asking about metabolic syndrome. This metabolic syndrome, out of the 5, 3 should be positive. Abdominal girth of more than 90 and 80 in male female, triglycerides more than 150, BP more than 130/85, HDL should be low, and fasting glucose should be high. Now main question they are asking this, what is not there? LDL is not there. Okay, LDL is not there in metabolic syndrome. That's the most repeated question. So abdominal girth, BP, triglyceride, HDL and fasting glucose. Okay, no LDL in this picture. What are the complications of diabetes? Basically diabetes, it's affecting the vessels. So you can have retinopathy, neuropathy, nephropathy or microvascular. Macrovascular, you have ischemic heart disease, stroke and peripheral vascular disease. But non-vascular also there, glaucoma, cataract, skin manifestations, gastroparesis, infections, or all these are non-vascular. Now you all know how to differentiate type 1 and type 2 diabetes. Remember the trick in our MCQ, age is useless. Don't look at the age to decide type 1 or type 2, although in practice we know usually type 1 are young people below 25 and usually type 2 diabetic are older people. In our MCQs actually the age may not help. What you have to look at to decide whether it is type 1 or type 2 is insulin resistance phenotype. If you see a patient having body mass index above 28 in Indian patients, if the patient has lipid problem and obesity comes with lipid problem, be careful. Classical lipid abnormality in diabetes is not LDL. LDL is non-specific. The thing that is affected in these patients typically is high triglyceride and low HDL. Okay, so diabetes main metabolic problems are high triglyceride and low HDL, not LDL. Be careful of that. Then most of these patients also tend to be having hypertension and acanthosis nigricans. So some pigmentation that is there in the neck, on the face, in the elbow, axilla. So acanthosis is a classical marker of insulin resistance. You see any of these things, that should tell you it is type 2. If you see antibodies are present, and in that mainly we look for islet cell antibodies and glutamic acid decarboxylase antibodies. If antibodies are present, they have high specificity to tell it is type 1 diabetes. So that is the major way how you differentiate and tell between type 1 and type 2. Now MODY is a condition that is monogenic. This is monogenic, means single gene problem. Remember type 2 diabetes, you may inherit the defect, but if your lifestyle is good and if your diet is good, stress is not there, you can delay the diabetes. Before you die, you may not get it. You can skip it actually. MODY is monogenic, single gene problem, and doesn't matter how the lifestyle of the patient is. It has got high penetrance and the patient cannot escape it. He will get the disease and he will pass it on to the next generation. It's autosomal dominant. There's a reason why there's no skipping here. 3 generations, grandfather had it, mother had it, now son has got it. So without skipping, you will see 3 generations will have diabetes and most of them will develop it in younger age. This is not a peripheral resistance problem. In this condition mainly, the beta cells that are there, the beta cells should get the glucose feedback. The glucose will go through many steps and that ultimately will give the feedback to the beta cell that will allow the insulin to be released. This feedback process is damaged. This is the sensing problem. And unless glucose is sensed, beta cells can't release insulin. The sensor pathway is broken here. That's a problem in maturity onset diabetes. We bypass the sensing by using sulfonylurea in the treatment. Sulfonylurea doesn't care glucose is there or not there. They are potassium channel blockers. By blocking potassium channel, they will cause insulin release. So the treatment in MODY is low dose sulfonylureas. This is not an autoimmune disease, so no antibodies. This is not a patient with insulin resistance, so no obesity. So those things you don't see. This is the feature of MODY. Diabetic ketoacidosis and hyperglycemic hyperosmolar state. What really hits the patient is if you understand, you can answer the questions very easily. What really hits the patient is ketone bodies, which are because insulin is deficient. Remember that insulin insulates the body, it makes the fat. Absence of insulin, fat will break. Fat breaks, releases fatty acid and they will convert into ketones. So this excess release of ketone, for it to occur, either the insulin should be low or the neoglucogenic hormones like glucagon should be high. So one of these two must have happened. Usually this is a type 1 diabetic patient who is either newly diagnosed or stopped treatment. They have stopped treatment. But it can occur in type 2, but whenever it occurs in type 2, it's your duty to find the patient has some underlying stressor. because type 2 diabetes does produce some amount of insulin. The only way how type 2 can get diabetic ketoacidosis is neoglucogenic hormones must have spiked up, and that is mainly because the patient has got some stressor. Now stressor can be acute MI, can be infection, can be stroke. Some stressor is there. So whenever we do rounds and we are seeing a DKA patient, if somebody says it's a type 2 patient who's got DKA, first question is, what's the ECG? Did you check for MI? Is this patient having a stroke? Is there an infection, urinary infection, pulmonary infection? What's the reason why DKA occurred? So many times we've seen key students manage the DKA nicely, but they don't search for the underlying stressor. And sometimes, unfortunately, the patient had an inferior wall MI. That's why the IV fluids do not cause pulmonary edema. But they have given fluids that helps in inferior wall MI also. But they missed an MI, and whole night patient has been managed without getting an ECG done in a DKA patient. That's very sad. So don't allow such scenarios to occur. Check the stressor. In a type 2 DKA, check for stressor. Type 1 is very simple. They would have stopped the insulin. The glucose level is between 250 to 600 in a DKA, and 600 to 1200 is the kind of glucose you'll see in HHS. So the main concern here is too much ketone bodies will cause severe acidosis. And you might see the pH as low as 6.8 to 7.3. And many of them will have a pH of 6.9. And you might say, sir, can the patient be alive? Yeah. This patient has got severe shock because severe acidosis causes vasodilation, and the BP will crash because of that. So the whole problem in this patient is the acidosis. Because of the vasodilation that ensures the BP is going to come down. The problem in this condition is not acidosis. There is no breakdown of fat because insulin action on fat is still there. But it's got a relative resistance problem. Means you can see it's got some action on the fat, but on the muscle is becoming weaker. So glucose can't go inside the muscle. So that lack of glucose is basically entering inside the muscle is building up. Still some insulin is there because the HHS happens in type 2 diabetes. Type 2 diabetes, not in type 1. So fat is not breaking, ketones are not coming out. The only issue is glucose not entering inside the muscle. It will build up in the blood. Normal young person would have got thirsty, would have drank water, diluted the glucose. This elderly person not drinking, their thirst senses are weak, they don't drink water, and the osmotic climbs. The osmotic is what kills them. It can go anywhere between 330 to 380. So what hurts this patient is the very high osmotic force. What hurts this patient is the severe acidosis. So that's the broad concept between the two. Now mainly questions are in the management. In a patient with DKA and HHS, both of them the treatment is IV fluids and insulin, correct? But in a DKA, whenever you start, the first step is always IV fluids, and we start with normal saline. After 1 hour of normal saline, we add the patient on an insulin drip. Whenever you need to add an insulin drip, it is very important that you have to have a potassium report in your hand. If the patient has got a potassium below 3.3, then insulin is contraindicated. Okay, below 3.3, don't give insulin, contraindicated. At the start of the treatment or in between the treatment, anytime potassium touches 3.3, stop insulin. It will not take much time to give the insulin to push the potassium inside the cell and cause hypokalemia. Hypokalemia will precipitate cardiac arrhythmias. Within 15-20 minutes, you can kill the patient if you continue insulin drip in a hypokalemic patient. So get the insulin checked. If less than 3.3, don't start insulin. Correct the potassium, then restart the insulin. Then start the insulin. If you see the 3 scenarios, they may give you an exam. Patient has DKA. At admission, patient's potassium was 7. You started the treatment. Potassium kept on coming down. You saw potassium touched 5.2. At this point, it kept on coming down because you're giving treatment. Insulin will keep pushing the potassium inside the cell. The moment it touches 5.2, you should start a potassium drip. And the potassium drip that we start is 10 milliequivalent per hour. Okay, because continued insulin will keep pushing the potassium further. So start a potassium drip. Okay, start a potassium drip. Let's say the patient potassium was at the time of admission itself was, let's say, 4.8. This is the third scenario. One is this. One is below 3.3, don't give insulin at all. Above 5.2, then just keep monitoring the patient until it touches 5.2, then start a potassium drip. If it's starting itself below 5.2, then start potassium drip, then only start insulin. So these are the important points. Mainly in the exam, for DKA management, potassium is what can kill the patient. That's why they ask in the exam. Hypokalemic patient, don't start insulin. That's the main thing. So start the insulin drip, provided you've taken care of the potassium, and then change over to N/2 saline. Okay, this is the general pattern of how we manage the patient. So normal saline, after 1 hour, start the insulin drip, continue the IV fluids, 2 to 3 liters of normal saline you have given, then afterward change over to N/2 saline. Okay, insulin drip, look at the potassium to decide the insulin drip. Less than 3.3, don't give insulin. Potassium is high, start insulin drip. Keep monitoring, touches 5.5 potassium, start potassium drip. If at the admission in the hospital potassium was below 5.2 already, start potassium drip, then start insulin drip. If it's below 3.3 at any time you are mid up thing, you should stop the insulin immediately and allow it to go to the upper limit and restart the insulin. So this is the main concern of decay. So I think this is what they test in our exam. Now if you look at the nephro, if you see WBC cast is pyelonephritis, interstitial nephritis, RBC cast is glomerulonephritis, broad waxy cast is CRF, hyaline cast, remember normal. Of all, the most important cast for us is muddy brown cast or tubuloepithelial cast, which is seen in acute tubular necrosis. Okay, this is the most important one. Muddy brown or granular or pigment epithelium cast we call it. This is a classical feature of acute tubular necrosis. Whenever you see a patient with acute kidney injury, kidney shutdown. Now when the kidney shut down, the problem may be prerenal, maybe renal, maybe postrenal. If it is postrenal, the most important clue will be any back pressure, hydronephrosis, pain will occur. So presence of pain and ultrasound will show hydronephrosis. These two things will help you to decide it's a post-renal problem. Post-renal. But if it is intrinsic renal or prerenal, there is no pain, there is no hydronephrosis. So between these, if you look at intrinsic renal, it may be ATN, maybe interstitial nephritis, maybe acute glomerulonephritis. Vascular problems are intertubular obstruction. Now, if it is a patient having interstitial nephritis, this generally has got some allergic component to it. So either the patient has got some drug or a infection like leptospira or a rickettsial infection. So some infection or a drug patient has taken. He's developed a rash as an allergic response. He has developed eosinophilia. He's developed high urine sodium, sterile pyuria, and as I told you, a WBC cast may be there. Okay, WBC cast may be there. All these features will tell you it is interstitial nephritis. So there's some drug, there's an infection, there's a rash. Skin rash is an allergic. Remember, even drugs can cause ATN, but the difference is the drugs that cause ATN are dose dependent. This kind of an idiosyncratic reaction. Interstitial nephritis is a idiosyncratic problem. Acute glomerulitis is easy because they'll come with hematuria and proteinuria. The moment you have hematuria, proteinuria, it's a glomerular problem. Tubules don't leak RBC out. So this hematuria, proteinuria is glomerular pathology. Vascular problems because vessels are throughout the body. A lot of systemic features will be there. Maybe it's a patient with malignant hypertension. Okay, this is a hypertensive emergency. Or the patient has got a vasculitis. But vasculitis will have a lot of systemic features. Patient may be having TTP, HOS. So all these, none of them are only pure renal. A lot of systemic features are there. Intratubular obstruction generally are drugs. And these drugs are methotrexate, then you have the indinavir, then you have triamtrene, okay, acyclovir, sulfa drugs. So typically these are the drugs that crystallize in the tubule and they precipitate, and since they are inside the nephron, had it been in the ureter, hydronephrosis would have occurred. They're still inside the nephron and their blockage inside them cannot cause hydronephrosis because inside the nephron. So they are causing obstruction, but this is crystal formation, methotrexate, indinavir, triamtrene, acyclovir and sulfa drugs. And sometimes you can also see precipitation of uric acid crystals or rhabdomyolysis. So tumor lysis syndrome, rhabdomyolysis, they may also be responsible. Although these two conditions actually may come with ATN also, tumor lysis syndrome and rhabdomyolysis. Anyway, 80% of patients that you see in hospital who have a kidney shutdown and the urine output is coming down, they are either prerenal or ATN. That's why all our MCQs are focusing on how do you differentiate prerenal from ATN. All the others are very rare. 80% of cases are one of these two. That's why in our exam, they keep asking, how will you differentiate a pre-renal failure from an ATN? And the main points to focus on is the Bun-Creat ratio, B1-Creat ratio more than 20, less than 20. Then look at the fractional excretion of sodium. Is it less than 1% or more than 2%? Okay, 1 to 2% is normal. Then look at the fractional excretion of urea. Okay, is it less than 35% or more than 35%? Then you're looking at the specific gravity of the urine. You know, the tubules are normal, and that's what happening in prerenal. Tubules are normal. They are the ones who concentrate the urine. So specific gravity will go very high. But if the specific gravity just looks like plasma, don't forget the filtrate is isoosmotic. So if it's going closer to plasma, tubules did not do anything. As it filtered, it came out in the urine. So the specific gravity is close to 1.010 or anything less than 1.018. Okay, this is the specific gravity of plasma actually. The more closer to plasma it is, it means tubules are not doing anything. Whatever filtered came out in the urine. Then you can also look at the muddy brown cast. Okay, which will not be there over here. They may say hyaline cast. Actually, hyaline cast can occur in any dehydration. And one more thing is you can look at the urine osmolality. The urine osmolality, if it's concentrated urine, it means tubules are working. If the urine is dilute, less than 450 milliosmoles, it indicates more likely it's a tubular necrosis. If the urine sodium is less than 20, urine sodium is more than 40, all these also will help you. Now, in general of all these, the reliable indicators to some extent for a sub-1 creat ratio, FeNA and fractional excretion of urea. So these three are what we really focus on. Okay, rest of them they may ask in exam for you, but you should know how to differentiate a pre-renal from a ATN. Okay, if you are able to differentiate, then you should be able to handle the questions because bulk of the patients are having this. And your main focus is to differentiate between them. Okay, mainly look at the B1 creat ratio. Okay, it's the same thing that I told you is there over here. If you are looking at a patient with CKD, the biggest clue for us to tell is CKD is ultrasound. And if you are seeing a small kidney, normal kidney size should be around 10 centimeters or more. If it's shrunken more than 8 centimeters, it's less than 8 centimeters size of the kidney, it is for sure got fibrosed. And once it's fibrosed, it's contracted a fibrosed kidney, for sure has to be a chronic kidney disease. Now you might also see loss of corticomedullary differentiation or echogenic kidneys. They are soft markers to tell you the patient has CKD. There are some exceptions where even though patient has CKD, kidney will not shrink. Diabetes, polycystic kidney, multiple myeloma, and to some extent even amyloidosis. All these the kidney may not shrink, but the first three are for sure. Amyloid most of the time will not shrink, so they are also, this is also included. So even though CKD is there, the kidney size may not become small in these conditions. Now what do you want to do in the management of CKD? Remember, control proteinuria is the main thing, ACE inhibitors, control the blood pressure. Then rest all the things are, whatever risk factors are there, you stop it. Protein restriction, although we say protein should be 0.8 gram per kg per day is allowed. Avoid anything that can precipitate acute kidney injury. Soda bicarb is used because that helps in decreasing fibrosis. But the most repeated question in our exam is, in a CKD they'll ask you, patient has come with anemia, what do you want to do? It's a anemia of, this is normocytic normochromic anemia in the patient. CKD patient is coming with anemia, what do you want to do next? Now here the trick is, don't answer erythropoietin, because before giving erythropoietin you have to ensure adequate iron stores are there. So check the serum ferritin, and if it is low, correct it. If it's low, you need to correct it. And unless you correct and make the iron stores normal, you're not allowed to give erythropoietin injection. So erythropoietin injection is last option. It's only after ferritin correction happens. Okay, first correct the ferritin, then only go for erythropoietin. Electrolytes, most important in our exams is hyponatremia. Sodium is less than 135. In that case, look at the plasma osmolality, because this is any hyponatremia, we expect osmotic force to be low. But if you find that the plasma osmolality is high, then that means you know that this plasma osmolality, plasma osmolality is nothing but 2 into sodium plus glucose by 18 plus blood urea nitrogen by 2.8, correct? So if you find that a patient with hyponatremia should have low osmotic force, if the osmotic force is high, then something else is increasing. Now B1 generally doesn't go so high, it must be glucose. So if the patient has got glucose or mannitol, that is the reason why you're getting the hyperosmotic state. And when you have high glucose, that high glucose will pull water out of the cell, patient will feel thirsty, and that excess water that is coming is diluting the sodium. So the problem is not so much the sodium, is the high glucose. That is the reason why the sodium is getting diluted. So in this, your focus should be on treating the underlying cause like glucose, not sodium. If the plasma osmolality is normal, it's pseudo-hyponatremia. When you draw a syringe, if lot of lipid or protein is occupying the space, amount of sodium you collect in the sample will be less. So machine will count less sodium. And this typically happens in patients who got triglycerides or a patient with multiple myeloma. So hypertriglyceridemia, multiple myeloma are causing pseudo-hyponatremia. Actually, body sodium normal. It's our measurement problem, because when you draw the sample, the protein displays the sodium. So you collected less less sodium in your sample. Hypoosmotic is true hyponatremia. Now, when you have a hypoosmotic hyponatremia, the patient has edema, then you're looking at these conditions. Okay, this is all edema. This retention of water dilutes the sodium. If the patient is dehydrated, he's losing sodium and water out of the body, but he's losing more sodium than water. That's why he's hyponatremic. But where is he losing the sodium and water? He may be losing in the kidney if the urine sodium is more than 20. If the urine sodium less than 20, he may be losing from the gut or skin. If the patient does not have edema or no dehydration, they're trying to tell you it is euvolemic. And euvolemic mainly SIDH or hypothyroid. And SIDH we already saw. Hypothyroid, without the thyroxine, ATP is not there. Without ATP, pumps are not working. Without pumps, sodium is not kept in the plasma. So remember, euvolemic hyponatremia, these two, SIDH and hypothyroid. When you have a patient with hyponatremia, they'll ask you to calculate sodium deficit. The formula is total body water into 140 minus sodium. In a male, 60% of the weight of a male is water. 50% of a male, half the weight of a male is water. 60% of weight of a male is water. So total body water, we take weight into 0.6 in male, weight into 0.5 in a female. So you calculate the total body water and multiply by 140 minus sodium. Remember the principle of correction in acute hyponatremia. What happened acutely, you correct acutely. So you can give 3% saline, although the risk of osmotic demyelination is still here, but it's very less. But in a chronic patient, because the body has adapted, you have to correct very slowly. So slow correction is the rule, and never correct more than 8 milliequivalent per day. So if the patient is 120, in the first day you have to target 128 or less than that. In the second day you get one more 8 milliequivalent you increase, and you are touching 136. So basically you are going slow in a chronic patient. If a patient developed acute hyponatremia within 48 hours, this is a marathon runner, this is a patient who is taking some drink, so whatever, they are all acute hyponatremia, you can treat acute. A chronic slow correction is the rule. So these are what they ask in exam for sodium. Potassium normal value is 3.5 to 5.5, and if it is more than 5.5, it is going towards hyperkalemia. Now in the patient with hyperkalemia, if the patient has a potassium that is less than 6.5, okay, this is between 5.5 and 6.5, right? Now here your concern is the patient may actually have pseudo hyperkalemia. This is because of lysis of the cells when you're drawing the sample. So you don't want to start treatment for a pseudo hyperkalemia. So first thing you want to do is check the ECG. If the ECG shows changes, you are really having hyperkalemia, give calcium. But if the patient is got a potassium more than 6.5, such high potassium more than 6.5 cannot occur by lysis of the cell. This actually is true hyperkalemia. Here we don't care about the ECG. So to summarize, below 6.5 ECG is important. Above 6.5, don't care whether ECG is showing changes or not changes. You give calcium. Important point, don't give chalk powder, don't give calcium carbonate. What you need to give is gluconate and chloride. Gluconate slow, chloride fast. That's the difference between how you infuse them. But don't give calcium carbonate. You need to give insulin and glucose. Diuretics, beta agonists, potassium binders. So remember potassium binders, now new ones are pathyromer and zirconium. We used to use sodium polystyrene sulfonate earlier, not approved because it can cause intestinal necrosis. In general, be careful about choosing soda bicarb in the treatment of hyperkalemia, because the studies are saying soda bicarb per se is not a treatment of hyperkalemia, it is for acidosis. And there also, it should not be used unless the pH is going below 7.1. And there also, just to bicarb if you infuse, the potassium gets affected very marginally, and that too very slowly. So soda bicarb generally is not a preferred treatment in hyperkalemia management. So that is a broad idea. If you remember, you are going to be okay. So don't go for sodium polystyrene sulfate now because it can cause necrosis. Don't give 50% dextrose. Any hypertonic fluid without insulin will pull the water out. If you give any hypertonic fluid including 50% dextrose, osmotic force the moment is high, it will suck the water out of the cells. It will leave the potassium to build up. Concentration of potassium builds up inside, potassium will leak out. So you're going to pull the potassium out. This is not a solvent drag. This is referred to as solvent drag. So merely infusing a hypertonic fluid, you can pull the potassium out of the cell, cause more hyperkalemia. That's why never give 50% dextrose without insulin. You have to give it with the insulin, not without insulin. Okay, don't think anyway he does not have diabetes, his body will make insulin. No, that's wrong logic. Give dextrose with insulin, even if he's not diabetic. So those are the important points to remember when it comes to endo. When looking at neuro part, remember headache, three main types. You have the migraine, tension type and cluster. The most common headache overall, as you all know, is tension type. What you see in the OPDs typically is migraine. All these are what we call primary headaches. If somebody gets the worst headache of their life, thunderclap headache, headache worsens with bending down, this is all intracranial pressure that is increasing. Headache worsens on coughing, this high intracranial pressure. So all these indicate the secondary headache and they are red flag signs. Okay, any nuchal rigidity is a red flag sign. It's all secondary headache. You have to be cautious. These are all primary headaches. Typically migraine lasts for more than 4 hours and it goes up to 72 hours. That means if you get a migraine today, it may continue tomorrow. It's still possible, it's migraine. Tension type also long lasting. Cluster typically lasts for 1 hour. Average duration is 1 hour. Okay, patient may have more than one episode per day, but it is 1 hour duration. So unilateral throbbing headache with nausea, or the patient may have photophobia, phonophobia, osmophobia, or the more the patient moves, more the headache. Some clues may be mentioned for you to tell it's migraine. Okay, and don't forget the intensity is very high, migraine. It cannot allow the patient to continue to work. A tension type headache is basically band-like, non-throbbing, gripping kind of headache, as if somebody is holding the head and compressing. There is none of these features. However, more recently now the guidelines are suggesting one of the two, photophobia and phonophobia, one of these may be present, not both. You may have photophobia in some patients, you may have phonophobia in some patients. Both should not be there. One of them may be there. But there's no nausea, no osmophobia, no relationship with movement. Cluster has migrainous features. This is a deep piercing periorbital headache around the eye, lasting for an hour. Patient will have nausea, photophobia, phonophobia, but the difference is, remember a migraine, the moment they move, the more the headache. They'll not move. They want to sit quietly, they want to lie quietly. A patient with cluster will be extremely restless. He just can't sit still. By just looking at the patient, you can tell this cannot be migraine. This fellow is not sitting quietly at all. This is a restless patient. So on examination, you may see some normal examination or you may see some scalp tenderness. The treatment, in acute treatment, mainly we use NSAIDs first. That doesn't work, then we go for triptans, or sometimes they just say mild disease, NSAID, moderate to severe disease, go for triptan. You can use ergot alkaloids and caffeine, but be careful, ergot sometimes can cause severe vasoconstriction and sometimes that can result in a Raynaud's patient. Don't use ergot, it will cause vasospasm. Patient has status migrainosus, is somebody lasting headache more than 72 hours. And you can use steroids, you can use dopamine agonists, you can use ketorolac hydration. Main point is in a status migrainosus, avoid opioids. That's the main question they'll ask in the exam. Don't go for opioids. Okay, but you can use other things. In a patient with tension type headache, usually examination normal, treatment is paracetamol or NSAID and prevention is tricyclic antidepressants. You can also use calcium channel blockers. Every headache lifestyle is important. Okay, you have to give lifestyle plus drugs. So TCS, CCBs for a prevention of tension type headache. Cluster headache is triptan and 100% oxygen. Now here is the trick. AIMS asked a question and they said triptan was one choice, 100% oxygen, but they said 3 to 5 liter. You should give 12 to 15 liter per minute. Only then it will work. So it should be very high flow oxygen. 3 to 5 liter oxygen will not work. So you have to use high flow oxygen. Prevention drug of choice is verapamil. Rest all are second line options. Okay, main drug you should remember is verapamil. In the prevention of patients with migraine, the first line drugs are these: beta blocker, valproate, topiramate, botulinum toxin. Okay, you have botulinum toxin, you have CGRP antagonists. Okay, CGRP antagonists, botulinum toxin are all the main drugs. In the MCQ, carefully see what else the patient has got to help you decide the drug. For example, if patient has got depression, then go for tricyclic antidepressant. If patient has insomnia, okay, if insomnia is there or depression is there and you want to take care of that also and migraine also, then tricyclic antidepressant is a good drug. If patient has got weight, high obesity and you want to take care of that plus migraine, then go for topiramate. If patient has got some anxiety disorder and migraine, go for beta blocker. And ultimately CGRP antagonists are for resistant cases. So CGRP antagonists we have eronumab, galcanezumab, fremanezumab and eptinezumab. Now, these drugs, particularly galcanezumab, is subcutaneous injection used once a month, showing very good results. But they are very, very expensive and generally not easily available in India. Botulinum toxin is only approved for chronic migraine. Definition of chronic migraine is patient should get 15 days of migraine in a month. Somebody gets occasionally episodic migraine, and once in a way migraine occurs, botulinum toxin will not work. It only works if the patient has got more than 15 days of headache per month. Then you can go for botulinum toxin. So broad concept that means is कि class 1 drugs are these. What does class 1 means? Definite RCTs, randomized control showing benefit. Beta blocker, valproate, topiramate, CGRP antagonist and botulinum. Even though TCAs are so good, they don't come under level 1 recommendation. Okay, but we still see TCAs are very good. Now, problem with calcium channel blocker, some studies are showing benefit, some are showing not so beneficial, but the advantage is they are very safe drugs. If you cannot decide whether it's migraine or tension type, then generally calcium channel blocker is the drug to go for. And then finally monoclonal antibodies, as I told you about them. So these are all the various drugs that we use in the patient with migraine. When you look at Parkinson's disease, patients are going to have tremor, rigidity, hypokinesia and poor postural reflexes. Remember Parkinson's, the theme is it should be asymmetric. The patient should not have symmetric features, it should be asymmetric. The earliest feature of Parkinson's was asked in one exam and the answer is constipation, followed by hypoosmia. This is the earliest feature. Okay, constipation, hypoosmia, of which constipation is considered the earliest. Then the next earliest feature that you get is REM sleep abnormalities. Normally, in the REM sleep, motor tone should be suppressed. This patient is not suppressed, so they have bizarre behavior in REM because they are dreaming, and whatever they're dreaming, they'll enact. They're walking in the sleep. All this is happening because they have REM tone is not suppressed in REM sleep. Okay, the muscle tone is not suppressed. Then comes the other features where you can get the excessive daytime sleepiness. The patient can have depression. All these will occur, then ultimately you get the core features of Parkinson. So this is a natural history of Parkinson. It starts with constipation, hypoosmia, sleep abnormality, excessive daytime sleepiness. Then the core features and then other features can occur in Parkinson. So this was an MCQ for us, which is the earliest feature. The earliest feature is constipation. Generally in our exam, your main point is to differentiate Parkinson from atypical Parkinson. The word Parkinsonism is nothing but rigidity and hypokinesia together. So you got rigidity, you got hypokinesia together, that is known as Parkinsonism. If you get Parkinsonism and if you see ocular problems, that is progressive supranuclear palsy. If you get Parkinsonism and you get early autonomic dysfunction, that is multiple system atrophy. Early means what? Even Parkinson's will have autonomic dysfunction, but they should occur within 1 year of diagnosing Parkinson's. So within a year of Parkinsonism, if autonomic dysfunction, severe orthostatic hypotension occurs, okay, this is autonomic dysfunction. This is multiple system atrophy. A patient has Parkinsonism and they have cortical problems. Now what cortical problems? If the patient has cortical sensory defects. Now you know cortical sensory defect like what? If you give an object in the patient's hand, like you give a coin, he has to feel the coin and tell what it is. For that, cortical sensation should be normal. So this is called astereognosis. If you write some alphabet on the palm, he should tell what it is. If he can't tell, that's agraphesthesia. So patient has cortical sensory defects. These patients can have dystonias. They can have behavioral abnormalities. Okay, behavioral abnormalities. These patients can have something called alien limb phenomena. What is this alien limb phenomena? Is patient has purposeful movement, not a chorea-like movement, random. He is taking some object and throwing it. When you ask him why did you do that, he says, I am not doing it. My limb is behaving on its own. This is called alien limb phenomena. So when you have these features, cortical sensory problems and all these, this patient has got corticobasal degeneration. So in our exam, mainly, they'll tell you Parkinsonism and many students, they see Parkinsonism and answer Parkinson's. Remember, rigidity and hypokinesia is not just Parkinson's. It can occur in number of conditions. So if you have Parkinsonism plus eye problem, can't look down, progressive supranuclear palsy. Parkinsonism plus autonomic dysfunction, multiple system atrophy. Parkinsonism plus cortical sensory defects, dystonia, behavioral problems, alien limb, corticobasal degeneration. So that is the theme of the questions that they ask in our exam. So first of all, Parkinson's is asymmetric. Next, you should understand that progressive supranuclear palsy and MSA are bilaterally symmetric problems. They're bilaterally symmetric. So in general, our idea is if they describe a patient having asymmetric features, your differentials are either it is Parkinson's disease or corticobasal degeneration. Last year INICT asked, okay, which condition patient has asymmetric Parkinsonism, that is rigidity hypokinesia asymmetric, and poor response to dopamine. Now poor response to dopamine means it is atypical Parkinson, correct? It must be PSP, MSA or CBD. But they mentioned asymmetric presentation, so answer was CBD. Remember, Parkinson's going to respond to dopamine. Okay, so in general, all atypical Parkinson's, poor response to dopamine, Parkinson's response to dopamine. Finally, the question will be built on which is symmetric, which is asymmetric. Both sides equal rigidity, both sides equal hypokinesia. Never test both hands at the same time. You test one hand, then test the other hand, and both, if there is symmetric, both are slow. This also slow, equally slow. Bilaterally symmetric, the answer is progressive supranuclear palsy, MSA. But if it's asymmetric, it's Parkinson and CBD. So this is how the approach is. Okay, that's what we are seeing over here. So you got Parkinson's core features. Look at the atypical Parkinson. They'll be bilaterally symmetric. Ocular problems, patient has got vertical gaze issue. He can't look up, he can't look down. Down gaze goes first, then up gaze. They may have something called square wave jerks, which you can only record, you can't see. But when the eye moves, it bobs up and down like this. This is known as square wave jerks. Patient may have dystonias, axial rigidity, postural instability, and they have something called hummingbird appearance in the MRI. These are all features of PSP. Multiple system atrophy is also called shy-dragger syndrome. Very early severe autonomic dysfunction should occur within a year of Parkinsonian features. Again, this is bilaterally symmetric. Corticobasal degeneration is asymmetric, just like Parkinson's. These patients will have dystonia, sensory problems, they may have other cortical problems, but the classical feature is alien limb phenomena. So Parkinson, atypical Parkinson, how to differentiate? One is generally Parkinson asymmetric. This is symmetric except for CBD, which is asymmetric. Good response to dopamine, this poor response to dopamine. This is anchor point for us. Usually tremor is a feature of Parkinson, but here is the problem. You can get a tremorless Parkinson. Remember, in Parkinson, of the 4 features, the most useless feature for us is tremor. You can have Parkinson without tremor. What is must to tell Parkinson is rigidity and hypokinesia. Tremor may be there in 75% of patients with Parkinson. 25% may not have tremor. So if you don't have tremor, it is more likely to be atypical Parkinson, but can be Parkinson also. But if tremor is there, that will help. This is going more towards Parkinson. Now, rigidity more in the limbs, Parkinson. Rigidity more in the neck, in the trunk, axial rigidity, atypical Parkinson. So these are the ways how we differentiate and tell, is it Parkinson or atypical Parkinson. So MCQs is constructed in a way, and you should know how to differentiate. So don't just see rigidity, hypokinesia and answer Parkinson. Look carefully in the MCQ. If they're saying he can't look down, progressive supranuclear palsy. He's got early autonomic dysfunction, multiple system atrophy. He's got alien limb phenomena, CBD is the answer. If you got classical tremor with main Parkinsonian feature response to dopamine mentioned, it is Parkinson's disease. So if you look at Alzheimer's disease, sometimes the pattern of fall will help you. Forward fall is more classical of Parkinson, backward fall is more classical of atypical Parkinson. But they are saying now that is not very defined feature. It may help, may not. Forward fall Parkinson, backward fall is atypical Parkinson. Okay, reason for avoiding opioids in migraine. Migraine, if you give opioid, it's supposed to take away the effect of triptan. Now the patient will get addicted to opioids, and every time they get an attack, they'll come to emergency, take opioids and go home. Now you'll have new problem, and they'll start getting opioid addiction. So that's the reason why they are telling that once they get the joy of the opioid, then they are going to get addicted by it, because this part of it is psychological. Don't forget, migraine is psychosomatic. Many times migraine starts when the people are studying for entrance exam. The moment they get the PG rank and they join PG, migraine goes away. So you can understand it's not so much organic, it's partly psychological also. So when you look at a patient with dementia, you got the 4 A's. In Alzheimer's, earliest feature is amnesia. Okay, apraxia, aphasia, agnosia are there. Amnesia is the main thing. It starts with amnesia and progresses. That is Alzheimer's for us. If you see patient having visual hallucinations, REM sleep, this was asked in the exam. Which dementia comes with REM sleep? What is REM sleep? Same, REM muscle tone is not suppressed. So because of that, whatever he's dreaming, he will enact in his dream. Bizarre movements he'll do in his sleep. That is REM behavioral disorder or REM sleep abnormality. So this fluctuating sensorium, these three things, particularly visual hallucinations, fluctuating sensorium, and I forgot to mention here Parkinsonism. In this list, Parkinsonism is not there. Parkinsonism. So these three things, 1, 2, and fluctuating sensorium, are known as the core features. According to the American guidelines, even REM sleep problems come under core features of Parkinson. Sometimes in the exam they ask, what are the core features of Parkinson, of Lewy body dementia, core features of Lewy body, visual hallucinations, Parkinsonism. What is Parkinsonism? Rigidity and hypokinesia, sleep problems, delirium. These 4 things are known as core feature. The problem with REM sleep abnormality is some guidelines don't put it in core, some of them put it in core, so plus or minus. But all the others are supportive features. What are the supportive features? Capgras syndrome, increased sensitivity to antipsychotics. They'll develop neuroleptic malignant syndrome. Then autonomic dysfunction can occur. And don't forget that Lewy body memory is not affected. Some students have the wrong idea. They think dementia means memory. No. Dementia means one of the cognitive functions is gone, or some of the cognitive functions are gone. There are many cognitive functions of the brain. Memory is just one of them. Aphasia, behavioral abnormality, visuospatial, executive functions of the brain, problem solving part of the brain. They're all multiple cortical functions. In some of them, okay, sorry about this. Okay, so if you find that the patient has got these core features, it is Lewy body dementia. So again, I'm telling you, don't think memory is dementia. Memory is one of the features of dementia. It may be lost, it may be novel. In Alzheimer's, it is lost. In Lewy body, it's not much affected. Frontotemporal dementia is a behavioral abnormality. Okay, it's a behavioral abnormality, and the main thing these patients will come with apathy. They get some indifference. Okay, indifference to family members. You may see aphasias, progressive aphasias in this patient. They are not aware of their own deficits, and the patient may have hyperphagia. They start developing an obsession to eating. They get some obsession to eating disorder. Okay, they keep ordering something in Swiggy, Zomato, and they keep ordering for like 10 people, and they constantly keep looking at the food. This is a new obsessive feature they have towards food. Hypersexuality may occur, and you may see association with with amyotrophic lateral sclerosis. So FTD and ALS, they have a 20% relationship between the two. This is a condition where the patient's occipital lobe and parietal lobe is normal, so drawing is spared. Okay, you don't see any problem in the drawing. So these are all the features of frontotemporal dementia. So questions that are asked in Parkinson's treatment. So Parkinson's treatment, only thing is, we used to start with levodopa carbidopa in the Parkinson treatment, but we still use levodopa. Problem with levodopa is you can develop something on-off phenomena. When the patient is having levodopa, as the age of the patient increases and the Parkinson's disease progresses, the dopamine does not stay in the therapeutic window for long. Too much dopamine, patient will have movement abnormality like chorea. Too little dopamine, the patient will get off phenomena. In between, the patient is on. This on-off phenomena is the main challenging problem in Parkinson. So main question they ask in treatment is, how do you treat the off phenomena in Parkinson's disease? So Parkinson's disease, the treatment for off phenomena is, one, we have a new drug now called istradifilin. Okay, this drug istradifilin reduces the on-off phenomena significantly. That's A2A. It's an A2A antagonist. Okay, it's a A2A antagonist. This one new drug that has come that reduces off phenomena. Secondly, you can use injection like apomorphine. Third is, see, the whole problem is when the patient is becoming motionless, means frozen. He is not able to move. He is not able to talk. He is not able to say anything. That is off phenomena. You need to get him back to on state fast. You can't give a drug that now you're giving, he is now immobilized, you are expecting it to work tomorrow. No, now immediately. So that's why it has to be some injection, or it has to be something that works fast. You can give dopamine, but it has to be delivered in such a way that it acts immediately. Like you must have got a gynostomy in place, and you're giving the drug immediate action. Immediately it's absorbed and you get the thing. So we are trying to find ways how we can get the patient from off back to on. Ultimately, now we are going for deep brain stimulation. So deep brain stimulation looks like the future in patients with on-off phenomena. But the thing is, istradifilin, I think they may ask, because it's a new drug. Injection apomorphine is like a rescue treatment in on-off phenomena. and ultimately it's going to be deep brain stimulation. We can try to deliver dopamine and allow it to absorb fast in the body, but that is still difficult to do in most patients. So this is the main concern of Parkinson. On-off phenomena, how do you treat the off phenomena, is a challenging issue. Is Parkinsonian plus syndrome same as Lewy body? No, Parkinsonian plus syndrome are these three things. Okay, MSA, CBD and PSP are known as atypical Parkinson. They are also referred to as Parkinson plus syndrome. What is plus? The plus in them is eye problem in PSP. The plus in this is severe autonomic problem. The plus in this is cortical sensory defects and alien limb phenomena. Okay, this is plus. Additional to Parkinson, something is there. Now, you may put Lewy body dementia under type of atypical Parkinson, but this is not really considered atypical Parkinson. This condition is basically a type of dementia where Parkinsonism is one of the features. Okay. Now, you might say even Parkinsonism can develop dementia. Now, the guideline says patient has Parkinsonism, and after 2 years, if the patient develops dementia, that is Parkinson dementia disorder. If the patient has Parkinsonism and within 1 year of Parkinsonism, if the patient develops dementia, then he's got Lewy body dementia. So this is how we differentiate. So the P here is Parkinson's, the D here is dementia. So between Parkinson and dementia, more than 2 years gap is there. Parkinson dementia disorder. Between Parkinsonism, which is rigidity hypokinesia, and dementia, less than 1 year, it is Lewy body dementia. So that is how you are going to look at it. But don't forget, the core features must be there to tell Lewy body. What are the core features? Visual hallucinations, REM problem, fluctuating sensorium, and Parkinsonism. They are core. Rest are all supportive features. Frontotemporal dementia, mainly behavioral problem. Aphasias may be there. Drawing is paired as an MCQ. What is paired? They keep asking. In Lewy body, memory is paired. In this condition, because occipitoparietal area is not affected, because parietal lobe deals with spatial orientation, that's the reason why drawing is spared in this patient. Creutzfeldt-Jakob disease is a prion disease. PRPSC formed. PRPC is normal, converts to PRPSC. This PRPSC, by merely touching PRPC, it can convert it to PRPSC. It makes it beta helical. Patho shows vacuoles in the brain, that's why it's called like spongiform encephalopathy, and you can get fibrosis. The clinical features are basically the patient will come with rapid dementia. So you can initially comes with weight loss and some kind of anxiety initially, then more behavioral abnormality, visual hallucinations, depression, intellectual problems will occur. Ultimately, the patient becomes vegetative state. Now, vegetative, we don't say coma here because the patient's eyes are open and the patient responds to oral command to some extent. This is called akinetic mutism, and this is a type of stupor. So this was asked in one of the exams. In a CJD, what is it that you get in a vegetative state? It's not really coma. It's a state of akinetic mutism, and that's a type of stupor. The hallmark of this patient is myoclonic jerk, which are triggered by startling the patient. You give a loud clap, patient will suddenly jump out of the chair. This happens in 90% of CJD. The EEG will show generalized triphasic wave. Problem with this is these are not unique to CJD. They can happen in encephalopathy like hepatic encephalopathy, or they can happen in patients with uremic encephalopathy. So you have to rule out all those. But so EEG is not so important for us. MRI is more important. It will show cortical ribboning, and in patients with variant CJD, you can get something called pulmonar sign, which is pulmonar nucleus of thalamus will become hyperintense. So the main thing is cortical ribboning is a feature. The CSF will show increase in protein, and the protein that is increased in CSF is 14.3.3. The cell count is normal. So this is also one of the conditions where you get the dissociation between protein and cell count. So 14.3.3 again is not unique to CJD, but whichever dementia we have found it, the prognosis is very bad. Okay, the outcome is very poor. So all these are features that you should look at in a patient with Creutzfeldt-Jakob disease. Amyotrophic lateral sclerosis is also called as Lou Gehrig's disease. The main things they ask in our exam is it should be a progressive asymmetric weakness. Slowly over months, motor weakness should spread. It should be asymmetric in nature. So it will involve the right leg, then it will involve the left leg after 2 months, then the right upper limb. So asymmetric motor weakness. In this condition, few points they keep asking, all are true about ALS except what is the, there is no bladder involvement, no sensory involvement, CSF is normal, and no eye involvement. Now you do see motor cranial nerves that supply the bulbar muscles like the tongue, okay, or the dysphagia, dysarthria, face muscles, all these cranial nerves will be affected. But even eye muscles are motor muscles. Okay, third, fourth, sixth also are mota, but they will never be involved. That's a peculiarity of this condition. You don't see ocular problems in amyotrophic lateral sclerosis. These patients generally have normal IQ, and you must have heard of Stephen Hawking who got this, but you should know that 20% of patients, when they develop frontotemporal dementia, then they are not having normal higher mental functions. Now, main features are they'll have mixed UMN element signs. So patient will have in the same limb exaggerated reflexes, but there'll be fasciculation, and you know fasciculation is an element finding. Weakness should be asymmetrical, should be bilateral. The most classical point in the MCQ is fasciculation in the tongue. The moment I mention fasciculation in the tongue, you're looking at an MND. You can have a problem in the SMA, the spinomuscular atrophy. This is element type. Okay, this is an element type of problem. So what is this spinomuscular atrophy is? Normally in chromosome 5, one of the genes that helps in survival of motor neurons is known as SMN1 gene. This SMN1 gene is mutated, and now depending on how many copies of SMN2 are there, the patient's symptom will vary. SMN1 is gone. The name is telling you survival of motor neuron. This gene is needed for survival of motor neurons. This is lost. But some people have 0 copies of SMN2. Some people have 3 to 4 copies of SMN2. But the problem is SMN1 produces a protein that helps to keep the neurons alive. This protein that it produces, let's say 100% protein. SMN2, each copy does 10% of the work that SMN1 does. But the good thing is SMN, sometimes you have SMN2 you have 4 copies. That means 40% of what this is doing it is able to do. So patient will have a mild disease. So once SMN1 is gone, it's infantile when you have 0 or 1 copy of SMN2. If you can have 4 copies of SMN2, then the disease will start late, it's milder. Infantile type is what they ask in our exam. Okay, childhood type and adolescent type rather, they don't ask so much, but mainly Wernicke-Hoffmann you should know, it's infantile type. Gross muscle wasting, fasciculation, again asymmetric involvement is classical, and the patient can have absent reflexes, progressive hypotonia, and your main concern is in this patient to differentiate from a myopathy. A myopathy usually bilaterally symmetric, this will be asymmetric in nature. Okay, usually in a myopathy, DTRs are last to be gone. They are preserved, they go last. Here, ankle jerk, knee jerk, biceps jerk will be lost early. So that is one way how to differentiate between a myopathy and a spinomuscular atrophy. IQ is not affected again. These children generally, the face is not affected. The body will go on becoming hypotonic and wasted. They die of respiratory failure. So in these children, the treatment that we have now is gene therapy, and this SMN1 gene is successfully given now using the adenovirus vector, and this SMN1 is called ONA. ONA means 1, Semno gene. It's marketed by Novartis and it comes in Zolgen SMA. It's the most expensive treatment in the world, costing around 14 to 16 crores per injection, so making it the most expensive treatment in the world now. Okay, it's under patent, so once the patent goes, obviously the drug becomes affordable. SMN2 gene is now not under patent, so it is there in the treatment. SMN2 gene is nusinersen, it's acting on SMN2, and that costs around 1 lakh. Still it's okay. The onasemno gene is, the price is, okay, this nusinersen is acting on SMN2. Okay, onasemno gene obviously is the problem for us, is too expensive. 16 crores is kind of out of reach of most patients. Now we look at the spinal cord problems. So in general that means SMA is pure element, ALS is mixed to UMN element pattern, that should be there, no sensory in both of them. Progressive asymmetric presentation is classical. Remember, symmetric weakness, if it ascends up, that is GBS, this asymmetric weakness. If you look at the spinal cord, if you're getting a problem in the posterior column deals with fine touch, joint position and all that. So spinocerebellar is basically cerebellum collecting information. Lateral spinothalamic tract is pain and temperature. Anterior spinothalamic tract is crude touch and pressure. And then you have the corticospinal tract deals with motor movement. Subcortical tracts deal with body tone and body posture. So these are the main tracts of spinal cord. Depending on where the disease is, you will have manifestation. If posterior columns are gone, that is tapes dorsalis. Patients will come with sensory ataxia. This patient typically will tell you, when I'm washing my face in the wash basin, I lose balance, because this Romberg's test is describing. As long as eyes are open, he can stand with his feet together. The moment he closes his eyes, he needs information from joint position vibration. If he cannot get it, he will lose balance and fall. So remember, Romberg's test is not for cerebellum, it is for posterior columns, and it is nothing but sensory ataxia. The biggest clue in MCQ, he is going to fall in the night, not in the daytime. Cerebellar disease doesn't matter day or night. Visual input has nothing to do with cerebellum. With the eyes open or closed, cerebellar disease can't stand with their feet together. Okay, they will lose balance. So that is Tapes dorsalis. If you see a patient having combined posterior column, both are myelinated. Corticospinal tract also myelinated, posterior column is also myelinated. Myelin problem, both will go. This is subacute combined degeneration. It's classical of B12 deficiency. Okay, B12 deficiency, but it can occur in anesthetic. Somebody is working in the OT, dealing with general anesthesia, nitrous oxide, copper deficiency, HIV. All these also can come with subacute combined degeneration. Combined is two separate tracts are gone. Corticospinal tract gone, posterior column is gone. So patient will have a UMN spastic weakness and they'll have sensory ataxia. That kind of pattern if you're getting this subacute combined degeneration. If you see sudden anterior two-thirds of spinal cord is gone, it's a vascular pathology. It is anterior spinal artery infarction. Okay, in this regard, the patient will have bilateral weakness, bilateral pain and temperature lost. What is preserved is joint position, vibration, fine touch is totally normal. Remember, posterior columns are not supplied by anterior spinal artery. Syringomyelia is a central cavity that expands. The tracts that are crossing in the front are the pain and temperature fibers of the upper limb, because typically syrinx occurs in the cervical area. Only the pain and temperature of upper limbs are gone. The lower limb seems to be fine. If pain and temperature lost in the upper limb but touch is normal, this is why it's called dissociative anesthesia. Okay, this is called dissociative anesthesia. Pain and temperature lost but touch is normal. This is dissociative anesthesia. Okay, so typically occurs in cervical cord, syringomyelia, pain and temperature gone, touch normal, dissociative anesthesia. Areas affected because it's mainly involving only cervical area, right? Not lumbar, only upper limb. So see, upper limbs are affected, shoulder, nape of the neck. In that distribution, you will see this problem. Okay, this is known as cape-like distribution. It is associated with Chiari malformation, and with Chiari, as you know, there is herniation of cerebellum. So cerebellar signs in addition with dissociative anesthesia will tell you it is Chiari. Okay, you get some cerebellum compression plus you see dissociative anesthesia combined picture, that will tell you the answer is Chiari malformation. If you see half the spinal cord is affected, is Brown-Séquard syndrome. What is happening ipsilateral and contralateral, what they ask in our exam. Remember that corticospinal tract and the posterior column don't cross. Whichever side you cut, same side weakness. Whichever side you cut, same side joint position vibration will go. But pain and temperature picks up opposite information. So whenever you cut on one side, opposite side information, pain and temperature loss will occur. So they have asked simple questions on, generally NEET asks one question every year. If you look at the last 5 year papers, one question they are asking from brainstem or spinal cord every year. So this thing that we discussed just now might be very, very important for NEET exam. Okay, INICT is not bothered about this. NEET is asking. In the brainstem, in general, anything starting with the alphabet S is in the side. Side means they are lateral. So lateral part of the brainstem is everything starting with S. Side mein hai. Side means lateral. So spinocerebellar, sympathetic, spinothalamic, sensory tract of fifth, all are lateral, tracts in the brainstem. In the lateral medulla, you should also include vestibular nucleus and nucleus ambiguus. So because spinocerebellar is gone, patient will have ataxia. Because sympathetic is gone, patient will have Horner syndrome. Spinothalamic is gone, patient will have pain and temperature loss in the body. This in the body, contralaterally. Sensory tract of fifth is gone, so patient will have ipsilateral loss of sensation. See, face sensation one side, pain and temperature in the body opposite side. Okay, this is a peculiar thing. So these patients will have a vestibular nucleus also affected, so they'll have severe vertigo. That because of vertigo, they'll have nausea, vomiting, and because nucleus ambis is gone, they'll have dysphagia, dysarthria. Even when they recover, see, very beautifully we can separate out air into the trachea and water into the esophagus. We keep drinking water, we're breathing also. But nucleus ambus is the one that's supposed to control that. And these patients, even when they recover, they start getting a lot of risk of aspiration because they drink. Somebody talks to them at that time, they can suddenly, the water is going in the airway. This is because of damage to the nucleus ambiguus. So they'll have dysphagia and dysarthria. What's the most common vessel affected? Vertebral artery, not Pica. It's called Pica syndrome, but the most common artery affected is vertebral artery. Medial medullary syndrome, only 3 things. It is going to come with medial lemniscus. So contralateral joint position vibration will go. MLF, it will result in internuclear ophthalmoplegia, although it's rare in medulla because MLF is connecting between midbrain and pons. So this may not really be there actually, but you get medial lemniscus, you will see motor pathway, contralateral hemiplegia will occur. Okay, so three things in medial medullary syndrome are: one, medial lemniscus will go, so contralateral loss of proprioception in the body. Then motor pathways go, so patient will get contralateral hemiplegia. And the third feature you get in this patient is 12th nerve palsy, so they'll have ipsilateral 12th nerve palsy. So these are three things that you can see in a patient with medial medullary syndrome. Okay, ipsilateral 12th nerve palsy, tongue weakness one side, hemiplegia on the opposite side, and loss of joint position vibration in the body in the opposite side. So the side where weakness is, same side joint position vibration will go, but the affected side, ipsilateral side, 12th nerve palsy will be there. Again, be careful, it is vertebral artery, then anterior small artery. In general, our rule is, if you see medullary syndrome, always say vertebral first, then something else will be there. In the pons, you got two syndromes, Willard-Gubler and Foville. Now, both affect motor tracts, so contralateral hemiplegia will occur. Both will cause ipsilateral 7th nerve palsy, but the difference is 6th nerve will go, resulting in diplopia. Here, the horizontal center is gone, so patient can't move both the eyes, and that is known as ipsilateral gaze paralysis. Okay, this patient will have ipsilateral gaze paralysis. So, one of the main questions they ask in exam, Willard-Gubler and Foville, which will have diplopia? It is 6th nerve palsy, so Willard-Gubler will have, Foville will not have. Foville, horizontal center is gone, so he can't move both here. He can't abduct this eye, he can't abduct the eye. So, because there is no mismatch between the two eyes, you don't get diplopia in Foville's. Midbrain, I think, is the hot favorite in our exam. You get Weber syndrome, and this is a cerebral peduncle lesion. These patients are going to come with posterior cerebral artery infarction. Motor tracts affected, so they'll come with contralateral hemiplegia. Third nerve palsy, so they'll get ipsilateral ophthalmoplegia. So usually the area affected is over here. This is the anterior area affected in patients with Weber syndrome. So this is the area where corticospinal tracts are passing. So they'll have, that will go down and cross, so they'll have contralateral hemiplegia. It is hitting the substantia nigra. The substantia nigra is also affected. So patient will have contralateral Parkinsonism. So what are all the features? Contralateral weakness, ipsilateral third nerve palsy, contralateral Parkinsonism, and patients may have, don't forget the corticobulbar tract over here, medial most corticobulbar. They are carrying information to 7th and 12th. So some contralateral 7th nerve and 12th nerve palsy may also be there in this patient. All these are components of Weber syndrome. Okay, to summarize then, contralateral hemiplegia, ipsilateral third nerve, because third nerve that is coming out from the same side, this area, this third nerve will be lost here, right? So you can see the patient having a lesion here. So even third nerve will go. So ipsilateral third nerve, okay, ipsilateral third nerve, motor tract will go down and cross. So contralateral hemiplegia, ipsilateral third nerve, substantia nigra. These are the structures affected over here. So that's why you're seeing same side third nerve, contralateral hemiplegia. The patients can have contralateral Parkinsonism and corticobulbar tract affected. So patient will have contralateral 7th nerve and 12th nerve palsy. All Weber syndrome. Benedict syndrome is a tegmentum lesion. So these patients will come again with ipsilateral third nerve. Red nucleus will go, so contralateral movement abnormality. Medial lemniscus is going to result in contralateral joint position vibration gone. North-Nagel syndrome is actually not tegmentum, it's actually a tectum lesion. Okay, it is a tectum lesion. It's third nerve palsy and there is contralateral cerebellar ataxia. Okay, this is a tectum lesion actually. So this is contralateral cerebral ataxia and third nerve. If you get Claude syndrome, it's Benedict plus North-Nagel combined picture is known as North-Nagel syndrome. So this covers the brainstem syndromes that you should be aware. Okay, what is Foville syndrome? Foville is basically PPRF. As you know that when you're looking at the PPRF, this is the horizontal control of both the eyes, not only one eye, both eyes. So one side 6th nerve, opposite side third nerve is controlled by the horizontal center. So if the PPRF is gone, remember each side you have a PPRF. There's a right PPRF, there's a left PPRF. The right PPRF will make the patient look to right side. The left PPRF will make the patient to left side. So in order to look to left side, the left PPRF will fire. 6th nerve is activated. It will cause abduction of this eye, and through the MLF, it will activate the third nerve. Through the third nerve, it will contract medial rectus. So this eye and this eye synchronize, they move. So if you are seeing there is a lesion in the PPRF, the patient can't look to that side. Same side he can't look. He can't abduct this eye, he can't adduct the opposite eye. So without the two eyes having a mismatch, they are sending same image to the brain, so they cannot have a diplopia. Diplopia is when the two eyes are sending two different images. So a horizontal center lesion will come with ipsilateral gaze paralysis, whereas 6 nerve palsy, 6 nerve palsy will come with diplopia. That's the difference between the two. Brown-Séquard syndrome, my advice is don't waste your energy trying to remember what happens at lesion and below lesion. Show me one question in the last 10 years where I've asked that. They're asking simple questions in the exam. Just remember below, don't bother about what happens at level. I can tell you at level, but it will unnecessarily confuse you. Just remember, on the same side, weakness is there. On the same side, joint position, vibration will go. On the contralateral side, pain and temperature is gone. Just remember that. That is enough for Brown-Séquard. Moving ahead, if you look at the stroke management, this is a hot area in our exams right now. Now, when a patient comes with stroke, the first thing you calculate is the NIHSS score, and if it should be significant, it should be more than 5. Now, for your level, you don't have to know what the components of the score are. Basic idea, anybody having aphasia with weakness, they will have a score more than 5. Okay, anybody having a aphasia plus weakness means it will cross 5. Don't worry about it. So it is a significant stroke. That means once you have got a patient coming with stroke, the first investigation you want to do, apart from vitals and all that, is get a non-contrast CT done. So when you are looking at a stroke patient, you got a non-contrast CT. The non-contrast CT will rule out hemorrhage and it will rule out massive edema. If these two are ruled out, then you focus on the glucose. If the glucose levels are not extreme, not below 60, not above 400, it is not a stroke mimic. Hypoglycemia can mimic like stroke. So you're ruling out extreme glucose values that can mimic stroke. Once these two are ruled out, then you focus on the BP, get the BP down below 95 or 110 and give thrombolytic therapy. Important point is, from onset of stroke till thrombolytic therapy, the duration is less than 4.5 hours. Once you have given thrombolytic, despite giving thrombolytic, in the CT angio, if it still shows large vessel occlusion, the patient should be taken. You already given thrombolytic, you're doing CT angio, still large vessel is blocked, that patient should go for mechanical thrombectomy. This patient is going to the cath lab and mechanical thrombectomy you're going to do. Okay, now physically you're going to remove the clot. If the patient comes after 6 hours, then not only CT angio, you need to do CT angio and CT perfusion both. Generally, MR is not recommended by the guidelines in Harrison. Go for CT angio, CT perfusion. CT angio will show large vessel. What do you mean by large vessel? Proximal branch, some DE branch of a branch deep inside. Anyway, we can't even reach that. Either way, a small branch affected will be small stroke. Large area affected in a proximal vessel. So if you find a proximal branch affected, this is middle cerebral, internal carotid, first branches of middle cerebral, or anterocerebral, posterior cerebral, they are all large vessel for us. So large vessel occlusion is there, plus CT perfusion shows mismatch. Okay, mismatch means infarcted area and area that is hypoperfused, that means that can still get affected. Mismatch is there. So if you say, for example, this is the area, this area is already affected, this area is hypoperfused. So all this is potential penumbra zone that can be lost. So this is mismatch is there. Mismatch and large vessel both should be present to do mechanical thrombectomy. Now we can do mechanical thrombectomy up to 24 hours. Okay, up to 24 hours there is a role of doing mechanical thrombectomy. So whenever a patient comes, what's the protocol? Let's look at what Harrison is giving first. If you look at how Harrison is giving, the first thing Harrison says, code stroke. Patient came within 6 hours from onset of stroke, not from in the hospital, from onset of stroke. Within 6 hours, get a CT, non-contrast CT first, rule out hemorrhage. Then check, is the patient eligible for thrombolytic. Eligibility number 1 criteria, patient should come within 4.5 hours. Okay, I'll show you the eligibility criteria. Under the eligibility criteria, patient should come within 4.5 hours. That's eligibility criteria. If the patient is coming within 4.5 hours from onset of stroke, give thrombolytic. After thrombolytic, it's not the end of the story. Shift the patient to cath lab again, get a CT angio done. If the CT angio, now that you give thrombolytic, clot should have been dissolved. But if CT angio shows proximal large vessel blocked still, then go for mechanical thrombectomy. Okay, this is the protocol. Patient came after 6 hours, first do non-contrast CT, rule out hemorrhage. Immediately in the same time, because now you can't give thrombolytic, correct? You're going to immediately go for CT angio and CT perfusion. If you find CT angio shows large vessel, CT perfusion shows mismatch, patient is going for mechanical thrombectomy. and mechanical thrombectomy can be done up to 24 hours. Now, where is the controversy? More recent studies, see the very large study that was done, known as the Dawn study, showed that thrombolytics are really amazing. They are going to have huge benefit. Subsequently, 8 studies have been done that could not reproduce the Dawn study finding. They are now raising question mark, do we need to give in a country like India, majority of places that cath lab and mechanical thrombectomy option is not there only. Here we only give thrombolytic. So in our country the answer is easy, just give thrombolytic. In countries like in US or say in tertiary institute like AIMS, they are saying that we have 3 CT machines. We have 24-hour team for stroke. Stroke team is there, 24 hours is there. So they are saying any patient coming with stroke now, we can get non-contrast CT done, no hemorrhage. We can bypass the thrombolytic and you can avoid 6% risk of hemorrhagic conversion. Directly do CT angio, and if CT angio shows large vessel, you can go for mechanical thrombectomy. That's what the tertiary institutes are arguing, that this risk of thrombolytic causing hemorrhage, we don't want to give. Directly we'll do CT angio, large vessel is there, mechanical thrombectomy, not large vessel, then we'll give thrombolytic. So that is the controversy. The point is, you cannot answer based on one institute's or somebody's feeling. It has to be international guideline. It has to be accepted guidelines. In most of the time, 24-hour stroke team is not available in the best of hospitals in Bangalore also, where we are, even best hospitals will not have 24-hour stroke team. So when patient comes, if you wait for the stroke team, after 5 hours when they come, nothing you can do. So here we are saying, just give thrombolytic first. Whatever benefit, let's get it. Because what is used in technique to opening a vessel is secondary. Open the vessel first. So give thrombolytic therapy, then go for CT angio. After CT angio, then go for mechanical thrombectomy. You understood this point? What's the risk of thrombolytic? Every 100 persons that we give thrombolytic, 6 of them will convert to a hemorrhage, 94 of them will improve. So it's a 6% hemorrhagic risk is there. Again, I'm repeating, do you follow what some individual person feels? No. Follow the guidelines. What do the guidelines say? As of now, maybe as in India, widespread stroke teams are available, they will bypass thrombolytic and go direct, do CT angio, do mechanical thrombectomy. In the future, hope is there. As of now, this is not the answer. The answer is, patient came, get a CT, no hemorrhage, get thrombolytic. If the patient within 4.5 hours, thrombolytic. Only after thrombolytic, CT angio. CT angio shows large vessel, mechanical thrombectomy should be done. I hope you understood the controversy and the clarity behind it. So after 6 hours, there is no controversy. After 6 hours, thrombolytic door is closed. After 4.5 hours, thrombolytic is sealed, closed. Anybody giving thrombolytic after 4.5 hours, risk of hemorrhage is not 6%, it is supposed to be 30-40%. So don't give thrombolytic after 4.5 hours, the door to thrombolytic is closed. Okay, number needed to treat is too big, don't give. After 6 hours, CT shows no hemorrhage, direct to CT angio, CT perfusion, mismatch is there, then go for mechanical thrombectomy. Okay, I hope this is clear. Now in this, basically we are expecting questions. Remember, stroke controversy is created because some platforms are giving direct CT angio when thrombolysis choice is there. They're telling go for CT angio. Actually, that question that came is basically changed. I don't know whether I can show you that image. I'll see if I can show you that question. But be careful. You just follow the guideline. What do the guidelines say? Patient came. If the patient came within 1 hour also, one thing that you don't want to do. What is the crime? What is the sin? If you do it, it's a sin. What is the sin? Don't do an MRI if patient comes within 4.5 hours. Every minute delay that you do in the treatment of stroke, there's 1.9 million neurons that are dying. Each minute delay, 1.9 million neurons are dying. So do not do MRI and waste a half an hour to 1 hour of the patient when millions of neurons are going to die in a patient who came within 4.5 hours. So first 4.5 hours, it's a crime if you say MRI in the answer. It will never be correct. So don't go for MR. CT you can do within minutes. MR will take time. So don't do MRI in a patient with acute stroke. I hope you understood this idea. So we've covered the stroke, and I think stroke is the main thing that they ask in our exam. They do ask indications, contraindications for thrombolytic. So just have an idea. Patient should come within 4.5 hours for you to give thrombolytic. Patient should be older than 18 years, and patient should not have hemorrhage or massive edema. Okay, in indication. In contraindication, if BP is above 185/110, despite the treatment, you give treatment, still BP is not coming down, then don't give thrombolytic. He's got high risk of bleeding. Patient is known risk of bleeding disorder. recent head injury, major surgery in 2 weeks, major GI bleeding in 3 weeks, recent MI. Now recent means how much? 1 month. Earlier they should tell 3 months. 1 month they're saying myocardial tissue is fragile. You give thrombolytic, it'll rupture. Free wall rupture means tamponade patient will die. So up to 1 month in a post MI, don't give thrombolytic. So these are the contraindications. You be familiar with this, otherwise you'll have problem. Okay, so somebody's posted the question. I'll just show you that question and you can see it. Let me just give me 1 second. Okay, this is a question, so I can see it. A patient presented with right-sided weakness and aphasia. As I told you, weakness and aphasia, it fulfills the NIHS's criteria of more than 5. Patient is going to get treatment. Patient came within 2 hours. Non-contrast CT is normal. That's what we expect. Don't forget CT will be normal in the first 12 hours. So we just doing CT, even though we know it will be normal, we're doing it to rule out hemorrhage and massive edema, correct? BP is already below 185/110, so you don't have to worry about giving labetalol. So what's the next step? Next step is give labetalol is out because already BP is below 185/110. MRI, I told you, is a crime if you do it in the first 1.5 hours. You're going to waste half an hour. A lot of neurons will die. CT angio is not the answer. As per the clear guidelines, the answer is thrombolytic therapy. Okay, give thrombolytic, follow the guideline, give thrombolytic, then do CT angio. And if CT angio despite thrombolytic still shows large vessel occlusion, then take the patient for cath lab, do a mechanical thrombectomy. So I hope you understand the correct answer here is D. However, let me alert you, INI CT when this question came, the correct question was, choice D was mechanical thrombectomy. It was not a thrombolysis. It was correct choice, I'm telling you, I know it. It is mechanical thrombectomy was the answer here. So if mechanical thrombectomy is there, nobody can do mechanical thrombectomy without CT angio. Answer they gave is correct, it is CT angio. But they changed the choice. This is not thrombolysis, it was mechanical thrombectomy. So you cannot do mechanical thrombectomy unless CT is done. So that's why the answer they're giving is correct, it is CT angio. But the fourth choice they modified. It is not thrombolytic, but mechanical thrombectomy. If it is thrombolysis like this, go for thrombolysis. That's the correct answer. Okay, go for thrombolysis, not CT angio. Okay, just follow the standard guidelines. Don't follow somebody's feelings and think. Okay, be clear about that. So the correct choice of mechanical thrombectomy is there. That's why the answer is got confused. The answer is CT angio over there. But if they change, if they say thrombolytic, thrombolytic is better answer, not CT angio. Now if you look at GBS, Guillain-Barré syndrome, okay, easy way to differentiate vascular dementia and Alzheimer. See, the very simple way vascular is, emboli are going, shower of emboli, they will hit the primary motor cortex, so patient will have spastic gait problems will be there and it will be spastic. So deep tendon reflex is exaggerated and the patient is going to have extensor plantar response. Alzheimer will not have gait problem, Alzheimer will not have exaggerated DTRs. If the MCQ says exaggerated DTR, and if the MCQ says patient has a step ladder pattern of worsening, so each time a shower of emboli comes, patient will deteriorate. One more, he's like this, one more shower of emboli, again he'll deteriorate. Again he's like this until one more shower of emboli, again he'll deteriorate. This is known as step ladder decline of patient's functioning. This is classical of vascular dementia. Alzheimer's will not come with step ladder decline. And Alzheimer will not have motor problems. It will not have exaggerated reflexes. Alzheimer's will not have extensor plantar response. That will not be there. Okay, so be careful. UMN spastic gait. Main point, gait problem. What kind of gait? Spastic gait. Spastic gait, if you see, and I've seen some students ask me, sir, how do you differentiate vascular dementia from normal pressure hydrocephalus? Both will have gait problem. Both will have urinary incontinence. Then how do you differentiate? Now the answer is very easy. The gait itself is grossly different. Remember, vascular dementia comes with spastic upper motor neuron type of gait. Normal pressure hydrocephalus comes with something called magnetic gait. It's a wide based. He'll put the feet wide. He'll drag his feet forward as if strong magnets are pulling the feet down. He doesn't have freely. He can't lift his leg freely. So it's a magnetic gait here. This is basically a spastic gait. Patient is going to have step ladder pattern here. That will not be there over here. Remember, normal pressure hydrocephalus. What's a triad? It is dementia. It is ataxia, that is magnetic gait, and they'll have urinary incontinence. This is the triad of normal pressure hydrocephalus. Remember, this is a type of reversible dementia. If you can connect the ventricles to the peritoneum and you put a ventriculoperitoneal shunt and the CSF drains out and the ventricles come back to normal size, then the dementia will get reversed. So it is a reversible provided you do the treatment in the initial stage. Even here, if you do it very last, the dementia will not improve. Okay, irreversible changes would have occurred. So I hope you understand what's the gait here? Magnetic. What's the gait in vascular dementia? Spastic gait. Okay, who will come with step ladder decline? Vascular, not NPH. What's the triad of NPH? Dementia, ataxia, urinary incontinence. Wacky, wobbly, wet. Wacky, dementia, wobbly, ataxia, wet is incontinence. So 45-year-old man, emergency with HbA1c 8 gram percent. 8 hours prior, he's got hemiplegia, BP 190, 110, normal. What is the next step in the management? So I don't know which question is this and who is giving it. I mean, this is not guideline. Okay, so the question that somebody is posting here, this is a 8-hour post. So in this case, definitely thrombolytic not allowed. Okay, as I told you, thrombolytic door closes in 4.5 hours. Okay, so definitely not thrombolytic. So this patient is coming after 4.5 hours. 8 hours rather. So in this you can do still something, and up to 24 hours you can still manage. Remember, non-contrast CT is done, and actually this patient should have gone for CT angio, CT perfusion study immediately. If there's a mismatch and it's large vessel occlusion, then the patient can go for mechanical thrombectomy, and even mechanical thrombectomy option is not there. BP is high, you can go for labetalol if you plan to treat. If you plan to take the patient for cath lab, then only treat. If you are not planning to take the patient to cath lab and doing mechanical thrombectomy, don't touch the BP until it crosses 220 by 120. Remember, this is called permissive hypertension. Okay, this is an important idea that they ask in an exam. See, in most places in our country, stroke teams are not there. So this mechanical thrombectomy question only doesn't arise. Only thing available, thrombolytic. Patient came after 4.5 hours. In our country, most of the places, there's no cath lab, no stroke team, so we're not doing mechanical thrombectomies. And what do you do then? In this case, don't touch the blood pressure. Don't try to treat BP until the BP crosses 220 by 120. Now you're saying this is malignant hypertension, sir. What are you saying? That is the guideline. Remember, mean arterial pressure, cerebral perfusion pressure, intracranial pressure. This is the formula. The perfusion pressure, the pressure at which blood is flowing in the brain, this is known as cerebral perfusion pressure. It depends on mean arterial pressure and intracranial pressure. When stroke occurs, edema will build up rapidly, intracranial pressure will rise. If intracranial pressure rises, the cerebral perfusion pressure will collapse. Body maintains the perfusion pressure by increasing the BP. This is the defense of the body. So if you try to treat the BP, the patient's perfusion will go. We want to keep the perfusion pressure above 70. We want the blood to flow in the brain. Skull is a closed space. There is no space. If edema is there, vessels are compressed. And if vessels are compressed, you will see perfusion will not occur in the brain. So body's response is hypertension. This hypertension is benefiting patient. If the patient came after 4.5 hours, you are not planning to do mechanical thrombectomy. Remember, for mechanical thrombectomy and thrombolytic, BP should be brought down below 95 or 110. You're not planning to do either of the two. Don't touch the BP in the first 24 hours. Let the BP be high. This is known as permissive hypertension. When you treat, if it is going about 220, 120, treat. Less than 220, 120, don't touch it. Let the BP be high. You will focus on reducing intracranial pressure. How can you reduce intracranial pressure? Anti-edema measures. Keep the head of the patient at 30-degree position. You can do craniotomy. Once the intracranial pressure comes down, body itself will get the BP down. It will itself control the BP. You don't have to treat the BP. It's a defense. Focus on reducing internal pressure, that itself will get the BP down. So I hope you understood the concept in stroke. Okay, whatever controversial areas we have covered. Okay, there is a favorable perfusion. Okay, how to assess that? Okay, favorable perfusion is basically if there's a mismatch. Okay, if there is a mismatch. So mismatch means you should have a volume that you can assess, that you can save if you are doing the thrombolytic. If the infarcted area and hypoperfused area is matching, even if you open the vessel, nothing will happen. If lot of areas are at risk and infarcted lost area is only small, remaining area is at risk, it will go. If you don't open the vessel, that will also go. So that is known as favorable perfusion. Which is better, TPA or tenecteplase? 2024, this year only I'm telling you, new guidelines are coming that is suggesting tenecteplase is going above alteplase, but this is too early for you to come in the exam for you because this is this year. More recent studies are suggesting tenecteplase is, initial studies were tenecteplase non-inferior to alteplase. Standard was alteplase, give alteplase over 1 hour. In between patient converted worsened, suddenly you stop the alteplase. That means you have converted to hemorrhage, you stop it. And we used to prefer alteplase because you're giving over 1 hour. Tenecteplase you give over the 15 minutes. And if you give it, intracranial hemorrhage, you can't do anything in between. But the recent guidelines are suggesting that the tenecteplase is more fibrin specific. Risk of intercranial bleeding slightly lesser. So according to the more recent evidence, tenecteplase is going up above alteplase. Although I doubt they'll ask this level of thing at your exam, but this is very recent, 2024. American Stroke Association, many talks and many things that I've heard also favoring tenecteplase over alti, but this is not clear. This is not there in the textbook still. So I don't think they'll ask you about this. So don't worry about it. Okay, break time. Okay, just we'll take a break in another 15 minutes. Okay, we will not even finish part 1. So GBS, basically so many types are there. The most common type is ADP. Patient typically has an infection or a Campylobacter. They'll have diarrhea or they'll have viral fever, and then they'll develop the weakness. So progressive weakness, areflexia, asymmetric weakness is the main thing. And these patients will have sensory. Some people have this wrong idea. They think GBS is only motor. No, the patient will have sensory, because the peripheral nerve conducts both motor and sensory. So paresthesias will occur, joint position vibration will be lost. Don't forget, this joint position vibration sense is conducted through myelinated nerves. Definitely joint position vibration sense is lost. Bilateral seventh nerve palsy will occur, autonomic dysfunction will occur, pains common in this patient, that's why radiculopathy we call it. CSF will show albuminocytological dissociation, and nerve conduction studies should be consistent with GBS. The main thing is these are preformed antibodies, so don't give steroids. Steroids can't do anything to the antibody. Before the antibody can attach to more myelin and cause more damage, pull the antibody out. So either go for plasmapheresis or go for immunoglobulin, one of the two. Doing both has no benefit, sequentially or otherwise no benefit. Just choose one of the two and never give steroids in a patient with GBS. The rest is all supportive care. Rest everything is just supportive care. Multiple sclerosis is an autoimmune problem. This is also triggered by sometimes Epstein-Barr virus or vitamin D deficiency. Those who don't have sunlight exposure, now we're telling, have more autoimmune problems. So in countries where away from equator, Norway, those areas, autonomic disease are very, very common. In India, good sunlight exposure, we are still seeing autonomic partly because we are not exposed to sunlight. So vitamin D is not anymore just a bone problem, but it is linked with autoimmune diseases. Okay, so vitamin D deficiency, Epstein-Barr virus, these are risk factors. Remember, multiple sclerosis should occur above 15 and below 50. Above 15 years, below 50 years. Okay, if it occurs below 15, you're not dealing with MS, remember that. Disseminated in space, disseminated in time. Out of the 4 areas, at least 2 areas should be involved. That is disseminated in space. Presenting features are blurring of vision, pain, fatigue, all these features will be there. So mainly in patients with MS, the idea is if you get only a motor, it's not MS. Patient should have sensory dominating over motor. So these patients will come with pins and needle sensation, paresthesias. They'll have some vibration problem, warm water kind of flowing on the skin. And some patients will tell you something called MS hug. There's a band-like squeezing, as if MS gave a hug to them. A band-like squeezing sensation around the trunk will occur. Then corticospinal tract and the surrounding inflammation can spread and damage surrounding tract also, so weakness can occur. You can get hermit sign, flexion of the neck, the two nerves that are demyelinated touch each other, shocking will occur. This is not non-insulated nerves, isn't it? The moment they touch, they'll cause shock-like sensation, will go down the spine in the legs. This is known as hermit sign. So what else? Optic neuritis features can occur. These patients can have internuclear ophthalmoplegia. They can have trigeminal neuralgia. All these are other features. Now, what are poor prognostic marker? NEAT, I think our NICT asked this. Male, older patient. Remember, MS typically occurs when the person is finishing the graduation, they are doing the internship, they are preparing for entrance exams. That's a typical age group when MS occurs in the early 20s, late 20s rather, 20 to 25, 20 to 30. That's the age group. If it occurs above the age of 30 years or 35 years, let's say, the prognosis tends to be more worse actually. So older age of onset, male patient, more infratentorial area, cerebellum brainstem, more relapses, more frequency of relapses, all bad prognostic markers. The treatment depends on how severe the scenario is. Mild disease, use Latimer. For mild disease, generally we use Latimer. For severe disease, we are going to use dimethyl fumarate in combination with other drugs. The ultimate drug that we have is natalizumab. Okay, this is the most powerful drug that we have. Natalizumab should be used provided the patient is JC virus negative, because otherwise they are prone for developing a problem called progressive multifocal leukoencephalopathy. Anyway, they are asking in the exam, in a primary progressive MS, what's the drug of choice? The answer is ocrelizumab. Okay, primary progressive MS, only one drug will work. Okay, primary progressive MS, remember, Only one drug will work, and that is ocrelizumab. Ocrelizumab plus interferon beta we try, but the main drug is ocrelizumab in primary progressive MS. For many years we tried no treatment. Now we have got this drug, ocrelizumab. So ocrelizumab anti-CD20, alemtuzumab anti-CD52. They don't ask alemtuzumab so much. Ocrelizumab is important. So what choice with drug? Mild disease, glatiramer. Okay, this spelling is wrong. This is glatiramer acetate, glatiramer. Mild disease because safety profile is highest in glatiramer. Drug that is most powerful, natalizumab. Most patients will end up on oral drug, dimethyl fumarate. Generally, this is the choice of drug that we have. You should differentiate multiple sclerosis from neuromyelitis optica. Neuromyelitis optica and MS, the difference is that patients with neuromyelitis will have optic neuritis. Even multiple sclerosis will have, but these tend to be more likely to be bilateral than unilateral. Remember, MS affects one side generally. It will not affect both optic nerves. So bilateral optic neuritis favors neuromyelitis optica. When you find that the transverse myelitis occurs in this patient, this transverse myelitis, it involves more than 3 segments. More than 3 segments are involved, which will never happen in MS patient. MS patient, small lesion. Vertically, more than 3 segments affected. Okay, this is suggestive of transverse myelitis, and this is going toward neuromyelitis optica. Because ariopostrema is involved, these patients will come with severe hiccups. Hiccups, vomiting, intractable, you can't control it at all. That's a feature of neuromyelitis optica. Okay, they can have other brainstem syndromes and all that. And in this patient, the treatment is plasmapheresis. Okay, plasmapheresis. You can use steroids. You can use mycophenolate, and you can use azathioprine. Okay, mycophenolate, and you can use azathioprine. Okay, steroids, mycophenolate, azathioprine, plasmapheresis. That's the main treatment for neuromyelitis optica. So how do you differentiate? Bilateral optic neuritis rather than unilateral usually. Transverse myelitis, when it occurs, it involves more than 3 segments. Area postrema will not be involved in MS. Here it is involved. So persistent hiccups. And other features are there. They may not help you. But apart from that, aquaporin 4 antibodies. Okay, aquaporin 4 antibodies also support the diagnosis of neuromyelitis optica. So all these are the features that you're looking at to make the diagnosis of NMO. So this covers the first part of it, and this is neuro part. So let's take a break, and then after that we'll continue.